on the theme of Respiratory Emergencies 1.0. Now I invite Dr. Ashima Ma'am, Emergency Medicine HOD in the NIMS, to talk a few words.
Thank you so much. So, I am Dr. Ashima, working as Professor and Head of Emergency Medicine at Nizams. And the dignitaries sitting in the first row and my colleagues sitting behind have inspired me all throughout my journey till now. It is beyond my words can express my thanks to Chandrasekhar sir. Whenever and ever I have called him for any help, he has not only enthusiastically listened to me, but with the same enthusiasm tried to solve my issue, which is all related to academics. So thank you, sir, for making sure that such small focused CME programs can happen. There is no doubt that these such programs will help the students to revise an entire chapter course from a course book within a span of 6 to 8 hours. And especially for those who are, younger, just entered into emergency, it would be so helpful to know should I do, how should I recognize, because emergency is a matter of seconds and minutes. So without further ado, I want to thank Dr. Venkat Kotam Raju, who has come all the way from UK, and he was visiting his parents, and then I said, no, sir, we have to get you to Warangal, and he has expressed yes. So thank you so much. And so without further ado, I who represent not only Nizam's Institute of Medical Sciences, but also an association of emergency medicine educators. We are here to train and impart and share and co-learn with you the art of dealing respiratory emergencies today. So thank you one and all, and I request the doctor to start the program. Thank you.
Thank you so much, ma'am, for accepting our invite and coming for the conference. Now I invite Dr. V. Chandrasekhar, sir, Principal of Mulugu Medical College, to speak a few words.
So, good morning, everyone. I welcome to the city of Warangal. So, as emergency PG, she is Rishita Sai, Dr. Rishita Sai. She is the first year emergency medicine postgraduate of Kakatiya Medical College, MGM Warangal. So that is the link between myself and Ashima Madam, who is the HOD emergency medicine at NIMS. So somewhere we are meeting in some of the emergency conferences, but the bond is developed like this. So when we wanted to start this program, one-day CME program on respiratory emergency is the madam theme actually. But anything, what are the issues in the emergency medicine updating? So that is the idea. So this is the first of its kind, respiratory emergencies 1.0. So good topics have been given by Dr. Ashima Madam, and wonderful speakers are there, like Dr. Venkat and other Gunashilan from Pondicherry, Dr. Gunashilan, Dr. Anusha from Salem, and our own colleagues from Warangal like Asif, and many from NIMS like the first speaker Rahul Rohan and many others. And I also sincerely thank you, the chairpersons, because Dr. Satish Chandra sir, Dr. Shiv Subramaniam sir. So they are the senior most physician and chest physician alike. So whenever we got any doubts, so we used to discuss with them. So hopefully many more are going to join. Actually 200 registrations have come. I welcome Dr. Asif. So many more will come. Hope this program will be a scientific bonanza for who are attending here. So without wasting much time, I welcome again, and I thank you all, faculty, chairpersons, and the delegates too. Thank you very much.
Thank you, sir. Thank you so much for your encouraging words. Let's start today's first topic of discussion, that is the exacerbation. Exacerbation is the worsening of the disease or increase in its symptoms. At the end of this topic, we will have increased of knowledge about these exacerbations. And the first topic of discussion is acute exacerbation of COPD, hosted by the chairpersons, Dr. Shiva Subramaniam, sir, MD, General Medicine, Senior Physician in Warangal and Consultant at Azara Hospital. And Dr. Satish Chandra, sir, Pulmonologist and Senior Chest Physicians in Warangal. Yes. Yes. And Dr. Vishwa Reddy, ma'am, consultant of emergency medicine in Apollo Hospital. Ma'am, please come on to the stage. Now I invite Dr. Rahul Rohan, sir, Assistant Professor in the Department of Emergency Medicine, NIMS, Hyderabad. Sir is going to present about the topic acute exacerbation of COPD.
Good morning, everybody. When Dr. Chandrasekhar sir asked me to chair the session, the topic he told was acute exacerbation of COPD. The moment he said the acute exacerbation of COPD, one thing struck to my mind. I remember certain incidents in ER. A patient comes with a SOB and the ER DMO saw that he is having a 75% oxygen saturation, breathless. He immediately started on oxygen, 100% oxygen. Saturation came to 100%. He felt happy. The next second, the patient became unconscious. He was intubated. So what is that? When the patient's oxygenation improved, why should he become unconscious? Because I think the key words in this is permissive hypoxia, permissive hypocapnia, permissive acidosis. All things should be remembered, and they are really important in such a situation. I really liked the starting of this session with such an important topic, and I am glad to introduce Dr. Rahul Rohan, who is Associate Professor in Emergency Department, and now he has graduated from Nizam's Institute of Medical Sciences, and the area of interest he is having is in quality improvement and advancements in the EMS system and community education. He is emergency department. He has DNB in emergency medicine. He did his MRCM, and he is an instructor in ACLS, BDLS, and he has many national and international conferences. And he is an author for some of the books, national and international publications also. He is an author, and I think we'll be having very nice starting session from Dr. Rahul Rohan. I thank the organizers for giving me this opportunity.
Thank you so much, sir, for such an introduction. And good morning, everyone who are attending the conference. So let's not waste the time, and we'll move forward to the topic. So my topic for the today is acute exacerbation of the COPD. So let's move into the topic. So actually what we are going to discuss in this time period. So in the 20 minutes of the time period, I am going to give a brief overview about the ACOPD. So how actually a person can manage the patient at the bedside, and what are the controversies actually we are facing, and actually what are the problems we are facing at the bedside. That is the most important thing. Actually, we have to make sure that we are clarity in the topic. So the next thing is why actually it is important to discuss the topic. The COPD, it has a major impact on the morbidity, healthcare cost, and mortality. How it is actually happening? Because it has a major impact on the morbidity, because it has accelerated lung function decline, that is measured in the form of a spirometry. And the case of it impairs the quality of the life, which makes anxiety, depression. At the same time, it plays an important role in because of the COPD, it has a morbidity in case of the developing comorbidities, diabetes, metabolic syndromes, and treatment-related complications are also having the morbidity. So these are the things actually the major impact of the COPD, and all these things together, it increases the healthcare cost. That means increasing the rate of hospital administrations, at the same time increasing the length of the stay. All these things together, there is an increase in the mortality. So this is the major impact of the COPD in case of a healthcare burden. So how actually we are going to deal with this? So because of that, what is happening is they have a guidelines are being created for to this. So what are the guidelines? What is the guidelines actually making us to do? The thing is, it is making a standard improvement for the standard care for the management of the patients with an ACOPD for the improved outcomes. So which guidelines actually we have to follow? See, in the we have so many guidelines such as GOLD guidelines, ATS guidelines, ERS guidelines, BTS guidelines, and CHEST guidelines. I'm very much confused actually. So what are the guidelines and which guidelines actually I have to follow when I'm treating the patient with a COPD? If we move forward and see, we have to choose actually the guidelines based on the patient-specific factors. At the same time, we have to choose the guidelines based on the local health settings and as well as the limited resources, and based on the emphasis follow-up and as well as the preventive measures. So it is based on the physician who has to make sure that if he three of the following things has to be taken care in the mind, and he has to make sure that which guidelines he has to follow. The next thing is we are going for the definition. So before the ACOPD definition, we have to make sure that what is the definition of the COPD. See, in the definition of the COPD, it itself states about the clinical features, it says about what is the pathophysiology, and it itself says about what is the etiology also. So if we say COPD, it is an heterogeneous lung condition. It is characterized by the chronic respiratory symptoms, including the dyspnea, cough, expectorations, and or exacerbations. At the same time, leading to the abnormalities of airway, that is bronchitis and bronchiolitis, and alveoli, that is emphysema, which leads to the persistent and as well as the progressive airflow obstruction. So if we know about the COPD, we have to know what is the ACOPD. So acute exacerbation, it is an event which is characterized by increasing the dyspnea and or cough and the sputum that worsens in the less than 14 days, which is characterized by or accompanied by the tachypnea and tachycardia, or often it is associated with the local and as well as the systemic inflammation, which is caused by the infections, pollutions, or other pollutants or other insult to the airways. So in the definition itself, we know that what is the clinical features. In the definition itself, you know what are the etiological factors. In the definition itself, you know what are the symptoms and symptoms which has been telling about the ACOPD. Then if we move forward and see what is the pathophysiology, I am going to discuss in this 20 minutes of the talk a simple pathophysiology. That is, we can see there is a normal healthy lung. If we see the healthy lung, the airways, there is an airway lining we can able to see. In case with a COPD lung, what is happening is there is an inflamed airways, damage to tissue is happening, there is a floppy of the elasticity happening. So overall what is happening is there is an increased airway inflammation and increased mucus production, and there is a marked gas stopping is happening. So overall, if the three things are happening which result in the COPD, the thing what is happening in the next is resulting in the dyspnea. So all these things will resulting in the dyspnea. So that is the reason the dyspnea is the most common and as the key symptom of the patient with COPD. But if only the patient presented with a COPD with a dyspnea, doesn't tell that it is a exacerbation of the COPD. So we have to make sure that we have to think that dyspnea either because of the exacerbation or it is because of any confounding or else any contributing factors are present to the COPD. So along with the dyspnea, there is a fever, cough, and sputum production is also there. If the dyspnea along with the fever, cough, and sputum production are present, that indicates there is a more favor towards the exacerbation. But if alone the dyspnea is present, we have to make sure that what are the other confounding factors. For that, we have to look what are the confounding or what are the contributing factors which are playing an important role in the case of an exacerbation of the COPD, which includes the pneumonia, which includes the pulmonary embolism and the heart failure. These are the more frequent confounding or the contributing factors for the exacerbation. And the less frequent you can see pneumothorax, pleural effusions, and myocardial ischemia and cardiac arrhythmias. So these are the things. So once we know about these are the things, then how can we evaluate the patient when presented to ED with all the symptoms of this dyspnea, fever, cough with an expectoration? What are the primary investigations which are available at the bedside? We know immediately once the patient presented to ED, we can assess the oxygenation, we can have a VBG, we can have a ECG, POCUS, CBC, and chest X-ray. First, we will keep the assessment of the oxygenation. At the end, we will discuss because as Sir discussed regarding the maintaining the saturations and how we have to maintain the saturations, what is the reason actually we have to maintain the saturations about 88% to 92%, we will discuss in the later slides. First, we will go for the VBG. So if we go for the VBG, the bedside investigation which can be done easily, everybody knows how to do the VBG and how to read the VBG. We know with the acidosis, if it is less than 7.35, if the PCOT is more than 45, we can label it as a respiratory acidosis. If we are simply labeling, but calculating the PCO2 or delta H by the delta PSO, we will have a value of the 0.8, which itself it is an acute. If the 0.3, it is a chronic acidosis. If it is between the 0.3 to 0.8, it is acute and chronic respiratory acidosis. And if it is less than 0.3, there is an associated metabolic disorder, that is a metabolic acidosis. If it is more than 0.8, there is a metabolic acidosis. So make sure that if the one disorder is going on, make sure that what is the secondary disorder and what is the reason for the secondary disorder. That is also the most important thing which we have to take care at the time of the assessment of the VBG. The next thing is about the ECG. Actually, what is happening? In case of the COPD, what is happening is because of the air trapping and all, what is happening is there is a flattening of the diaphragm is happening. Once the flattening is happening, there is a pulling of the heart towards the downside, and which is making, because the heart is fixed with the great vessels, with the greater vessels in the mediastinal, there is a slight rotation of heart is towards the right side. So the right ventricle is coming forward anteriorly, and the left ventricle is going posteriorly. So that is the reason there is a right axis deviation will be there, and because of the presence of this air trapping, there is low voltage complexes will be seen in case of V4 to V6, and because of the pulmonary vasoconstriction, there is the development of the pulmonary hypertension, which is leading to the right atrial enlargement and as well as the right ventricular hypertrophy. Along with this, there is a development of the arrhythmias, which is called as a multiple atrial tachycardia. The indications of the multiple atrial tachycardia, if you are COPD, that indicates that there is a high chance of the mortality. So these are the things actually we have to take care at the time of the presentation if you are seeing at the bedside. So the next thing, if you are moving forward, we know that we have done the VBG, we have done the ECG, and we have seen the chest X-ray. The next thing is available investigation is the POCUS. Everyone knows, we can see the first one, the presence of the barcode sign, that is a pneumothorax, which we have discussed, which is maybe the confounding factors or it may be the contributing factors. The next thing is the presence of the straight sign, which indicates the presence of an infection, that is a pneumonia. If you are going for the next thing, we can see there is a B profile, which is indicating then a heart failure. At the same time, you can see the echo window, right ventricular as well as the right atrial dilatation with the presence of the left D-shaped left ventricle, which indicates the presence of a pulmonary embolism. So these are the signs which can be seen in the bedside immediately, and we can able to identify these may be the contributing factor or these are the confounding factors which are playing for the role of the COPD. The next, if we move forward, yes, we have done the we know about the clinical features. Now we know what are the investigations we have done at the bedside. The next thing is actually we have to classify the severity of the COPD, how it is based on the mild, moderate, and as well as the severe. So for the classification of the COPD, now in 2024, the recent guidelines of the recent gold guidelines, there is a Rome proposal is there, and they have classified it into the mild, moderate, and as well as the severe COPD. In the mild COPD, they have taken the 5 components, that is the respiratory rate, heart rate, and as well as the presence of dyspnea, and as well as the saturations and the CRP. We are going to discuss about the CRP in the later slides. If the CRP is available, we can able to do at the bedside immediately. Otherwise, it is not possible to do at the bedside immediately. If the CRP available immediately, that is okay. If it is not, we can do it later. So if you are having the mild, the respiratory rate will be less than 24 with a heart rate of less than 95, and the resting saturations which are maintaining to the baseline saturations. These are the things actually we have to see, we have to label them as a mild. If you are going for the marked moderate exacerbation of the COPD, moderate severity, where there is heart rate will be raised, heart rate will be more, respiratory rate will be more, dyspnea index will be more, resting saturations will be less than 92%, and the patient will be requiring the oxygen support. At the same time, if you are obtaining the VBG, there will be a compensated acidosis will be there, and in case of the severe, the ones which are there in the moderate, that is 3 out of the 5 criteria which are fitting, it will be there in the severe. But along with that, if there are persistence of an acidosis in KBAS and ABG, that indicates it is a severe. So all these things we have done. Now we have to think about which patient actually is requiring the hospital assessment. The thing, the patient with the severe symptoms, that is sudden worsening of this dyspnea and high respiratory rate. At the same time, the patient is having acute respiratory failure. Patients with an onset of the new physical senses, such as the cyanosis and the peripheral edema. Patients with a failure of an exacerbation into the even after the treatment with the initial medications, and the presence of the serious comorbidities and the insufficient home support. So these are the patients who actually require the hospital assessment. The next, what we have done in the whole slides is we have assessed the patients with what are the confounding factors, and we have assessed based on the symptoms and as well as what are the signs, and we have seen the severity of the COPD, and we have made sure that where the patient has been taken care, whether the hospital admission or outpatient basis. At the same time, we have to make sure that what is the etiological factors, actually whether it is a viral, bacterial, or environmental. So if you move forward and see, we have done all these things, we have come to the treatment. So what is actually the goal of the treatment? The goal of the treatment of COPD is to minimize the negative impact of the current exacerbation. At the same time, we have to prevent the further development of the future exacerbations. This is the goal. How it is divided? It is divided into the pharmacological support and then as well as the respiratory support. If you see the pharmacological support, it is again divided into based on the bronchodilators, corticosteroids, and the antibiotics. And if you are going for the respiratory support, it is on the oxygenation and as well as the ventilation. So if you go and based on the available studies, more than 80% of the patients of the exacerbations will be managed on the outpatients, and this is based on the pharmacological therapies, that is bronchodilators, corticosteroids, and antibiotics. There is no need of the respiratory supports. So what about the 20%? For the 20%, actually, if the patient are admitted, patient are presented to the ED, we have to divide into the whether the patient is classified into whether into the respiratory failure or is fitting into the respiratory failure with a non-life-threatening or respiratory failure with a life-threatening. So here, if you see the key differences, use of the respiratory rate, accessory muscle, mental status. There, if the change in the mental status is directly fit to the acute respiratory failure with a life-threatening. At the same time, in case of a hypoxemia, use of the Venturi mask, but use of the FiO2 the 24 to 35%, but there is an improvement in the no respiratory failure phase. If it in case of acute respiratory failure without any, which is a non-life-threatening, there will improvement will be there, but in case of the life-threatening, there will be no improvement. Hypercarbia, there is an increased hypercarbia with elevated bicarb of more than elevated CO2 levels of more than 60 millimeters of mercury. At the same time, acidosis, the presence of acidosis. So this is the way how we are dividing the patient who is presented to ED, and we are assessing the severity, and the next we are dividing based on the respiratory failure. Yes, we have divided the respiratory failure. Now what about the bronchodilators? As we have discussed the pharmacological therapy. See, if we go for the bronchodilators, we are using short-acting bronchodilators. The short-acting bronchodilators, either using with alone or using with anticholinergic, there is no significant can be used. And about the data, what about the RCTs based on this use of this short-acting is there is no high-quality evidence based on the RCTs. If you move forward, yes, I am using the bronchodilator therapy. Now I am having the doubt that whether I can use with a meter-dose inhaler or whether I have to go with the nebulizers. See, there is no significant difference with the lung functions if you are using either with the MDI or either you are using with the nebulizers. But with the sicker patients, there is no possibility for to take with an MDI. That patient can be better go with the nebulizers. Now I am using the nebulizers. Now I have to go with the whether air-driven nebulizers or I have to go with the oxygen-driven nebulizers. The thing is, air-driven nebulizers is the preferred choice when compared to the oxygen-driven nebulizers because of the same concept, that is if you are keeping the oxygenation, if you are keeping the oxygen saturations more, then will be still it is deleterious in a patients with a COPD. That will be discussed in the next slides. So if you are now we know that we are using the short-acting bronchodilators. Now what is the role of the long-acting bronchodilators? There is the studies which are there on the long-acting bronchodilators says that there is no proven benefit. At the same time, if it is there, when how to start in the ED? It can be started at the time of the discharge or as soon as the exacerbation of the patient is suppressed. Now, what is the role of the methylxanthine? We have seen the many patients have been written with the methylxanthine even in a phase of exacerbations and all. The role of the methylxanthine is no in case of an exacerbations. If you are using the methylxanthine in an exacerbation, there will be significant side effects when compared to the normal patients. So if you are going with the bronchodilators, what is the dose? I always tell my students to go and see the respiratory vials, because what is the vial actually the dosing 2.5 ml, what is the mg of the 2.5 ml contains, because it is not about writing the writing the 2 respirators and give the nebulization. It's not about the 2 respirators and the given nebulization. It is the proper dose in the case of an exacerbations we have to provide. So if you go albuterol and salbutamol, that is a 2.5 mg. We can see that 2.5 ml of the respirator contains the 2.5 mg. It should be given every 20 minutes for the 1 hour. Then it should be 1 hour, then hourly for the 4 hours, then continuous nebulization. Make sure that if you are continuously nebulizing, there is a high chance the patient will be developing a tremors, tachycardia, and as well as the hyperglycemia. If you are using the meter dose inhalers, that's 100 micrograms per puff, we have to give the 4 to 8 puffs every 20 minutes for the 4 hours and 1 to 4 hourly as needed. So if you are going for the levosalbutamol, the dose is a 1.25 mg for the respulse. So now we know about the bronchodilators. Now we will discuss about what do you think, sir, I am going with the bronchodilators, since still I want to go and try with the adrenergic drugs such as epinephrine and as well as the terabutaline. As per the evidence suggests that there is no proven benefits over the aerosol therapy in case of the both epinephrine and as well as the terabutaline. Now if you are going through the medication, it is not only the thing that because once you are advised with the medications, the most important thing is how it is using. Whether if he is taking for the meter dose inhaler and as well as if you are going for the nebulization, if we are asking the patient to go for the meter dose inhaler, we have to explain that how actually the meter dose inhaler has to be taken. Because if he is taking the improper technique, then it doesn't going to affect the patient. So how we are going to remove the cap, breathe out all the air, and breathe in and also press down the inhaler, then hold the breath for the 10 seconds in case of the meter dose inhaler and slowly breathe out. That is the first thing. If you are using for the meter dose inhaler with the spacer, the same thing, breathe out all the air, press down the inhaler and slowly breathe in and hold the breath for the 10 seconds, then slowly breathe out. This is the technique actually we have to explain the patient attender during the discharge, and if you are treating the patient with a mild exacerbation in the ED also, we have to explain them how we have to take care of this. Now the next comes in the pharmacological therapy, the steroids. Why actually the steroids are playing an important role in case of an exacerbation, and when do you want to start the steroids and how many days you have to start the, how many days actually we have to continue the steroids. Why actually we are starting the steroids? See, steroids, they shorten the recovery time, they improve the lung function, plays an important role in the oxygenation, it reduces the risk of the early relapse, and it plays an important role in the treatment failure and has the decreases the hospital length of the stay. This is the reason, the benefit of the systemic steroids in the case of a ECOPD. At the same time, when actually we have to use the steroids, in the case of a moderate and other severe exacerbation, in case of this, we have to use the steroids. Sir, I am using the steroids, but I don't know what is the dose of the steroids. And if I am using, I know the dose of the steroids, I don't know how many days actually we have to recommend to continue the dose of the, to continue the medications of the steroids. This is the 40 mg of the prednisone along with the equivalent dose per the day, that is for the 5 days, which is recommended. And the longer course, if you are using, what happens? If you are using for the longer course, the patient will be developing the pneumonia and as well as increases the mortality. Then the route, sir, I am having the oral, I am having the IV. What medication I can use, whether IV or oral? Both oral and as well as the IV are the same efficacy, so I can go for the any of this thing. But if you see compare the guidelines, that is the gold guidelines, ATS, and as well as the BTS guidelines, we can see that only look for the corticosteroid duration. In the gold guidelines, it says about the use of the steroids only for the 5 to 7 days. In the ATS, it says about the 5 to 14 days, and the BTS is variable depending upon the severity. But the ATS guidelines is mostly focuses on the critical cases and the severity of the cases who are usually admitted in the ICUs and all. Gold guidelines, the steroid duration of the steroids, it is also based on the severity, but it recommends that only 5 to 7 days having the benefit. And if you are continuing the steroids for the more than 7 days, there is an increase in the mortality. So this is the thing for comparing the guidelines. If you move forward and see the steroids, what about the short burst of the steroids? Even if you are using for the short burst of the corticosteroid, it increases the chances of the pneumonia, sepsis, and as well as the death. And what about in a cases where I am in a setting, in a resource limited setting, I don't have IV medications to give for the prednisolone or methylprednisolone. So at the time of the pandemic, I have a nebulized budesonide. I can use or not? Yes, it may be an alternative, but it has provided, it is an alternative for the methylprednisolone. In case of a resource limited setting, it has a similar efficacy to the intravenous methylprednisolone. Now the role of the eosinophilia, when we are doing the CBC, we are looking for the neutrophils and as well as the eosinophils. If we are going for the neutrophils, we can know that it may be because of the neutrophilic predominance, maybe it is because of a bacterial infection. What about the thing about the eosinophilia? If you are seeing for the eosinophilia, the counts of eosinophilia more, the steroids, use of the steroids will be beneficial. But if you are giving for the CBC and the eosinophilia levels are low, then the glucocortical efficacy is also low if you are using the patients in case of the COPD. Then this is the conversion, busy slide. I mean, these are the conversion factors for the how to go with the prednisone, dexamethasone, and as well as the hydrocot and methylprednisolone with each other respectively. Now the role of the antibiotics. See, based on the available systemic review and the analysis, the thing is, why if you are using the antibiotics, there is a risk of short-term mortality, and there is a treatment failure by the 53%, and the clearance of the sputum by the 44%. So this is the reason actually we are using for the antibiotics, and this is the main role actually the antibiotics are playing. If you move forward and see what is the controversy, do you think that all the patients who are coming to ED requires antibiotics? No, all exacerbations are not caused by the bacterial infections. To know that, we have to look for what are actually the signs of the bacterial infection in case of the COPD patients. That can be seen that presence of the fever and cough with an expectoration. The presence of an expectoration, you can see that the color of the sputum also, if the color of the sputum is an yellow, that indicates it is a pus and it indicates that it is a bacterial infection. That is the most indicator. At the same time, if the color of the sputum is white, we can able to discontinue the antibiotic support also. So the sputum color also will play an important role whether to continue the antibiotics or not. If you move forward and see antibiotics, I want to continue the antibiotics for the shorter course and somebody wants to continue the antibiotic for the longer course. If you see for the shorter and as well as the longer course of the antibiotics, in terms of the clinical and as well as the bacterial outcomes, the shorter course has the better outcomes when compared to the longer outcomes. At the same time, if you are going for the shorter outcomes, it decreases the antimicrobial resistance and as well as the complications from the antibiotic therapy. So the duration, the recommended is 5 to 7 days. So role of the CRP, as we have discussed in the severity of exacerbation, the role of the CRP. The role of a CRP is more in case of exacerbation which are mild, and based on the CRP, we can able to titrate the antibiotics. But in case of an antibiotics, but it is mostly on the outpatient basis. But role of the procalcitonin if the patient is admitted into the ICU or in case of an emergency. The procalcitonin admission, procalcitonin based antibiotic therapy in patients with ACOPD is not good and it increases the mortality. So that is the reason there is no role of the procalcitonin used antibiotic therapy. Then if you move forward, the next thing is the respiratory support. See, respiratory support, as we have discussed, oxygenation and as well as ventilation. What is actually in an oxygenation? We have to maintain the oxygenation about 82 to 92%. Ventilation, we are going for the 9 NAV. Why actually we are going for the 80, why we are maintaining the saturations for the 88% to 92%? See, initially in the 1992s, and the concept was the hypoxic drive concept. That means usually anaxia, there will be CO2 is a stimulus for the CO2 is the stimulus for the respiratory center. In an older concept, if anaxia is there, because the patients with the COPD, there is increased levels of the CO2 drive will be gone. So the anaxia is the stimulus for the this respiratory drive. But this was an old concept, but the concept is that is not the proven, or it is not a completely, it is a fact and it is not fiction-based concept. So, but this concept covered actually the blanket therapy, that is the presence of the hypoxic pulmonary vasoconstriction and as well as the Halden's effect. This is a factor. This is the thing actually which plays an important role why we have to maintain the 88 to 92%. Because here we can able to see that when there is a when there is a hypoxia, because of the air trapping, in case of the COPD, there is an air trapping will be there at the alveoli, and there is a problem of the ventilation and as well as the perfusion. So what is happening when there is a air trapping? There is an increased levels of the CO2 in the alveoli, the diseased alveoli, and there is a decreased level of oxygen. At that point of time, there is a hypoxia is happening, and there is a vasoconstriction is happening. Once the vasoconstriction is happening, what is happening is once the hypoconstriction is happening, there is a shunt has been created. The shunt will guide the blood flow to the healthy alveoli. So at that point of time, it is providing the CO2 to wash out. But if you are providing the oxygen to this point of time, what is happening is whatever the CO2 is about to wash out is not washing out, and there is a ventilation perfusion which first still it is increasing. So there will be increased levels of the PCO2. That is the reason we have to maintain the saturations around the 88 to 92%. At the same time, the one more concept is the Halden concept. We know the hemoglobin is more attracted towards the oxygen, but if you are in case of the COPD, there is a raised levels of the CO2. If you are giving the more oxygen at that point of time, the hemoglobin bonded the CO2 also will be discharged and the CO2 levels will be increased in case of this. So that is the reason these two concepts plays an important role. That is the reason we have to make sure that the 88 to 92% is the maintenance of the saturations in case of oxygen. So what is the ventilations? So NIV based on the RCTs, the success rate of NIV is almost around the 80 to 85%. And we have to, what is the indications for the NIV is the respiratory anastosis with a PCO2 of 45 with arterial pH of less than or equal to 7.35, presence of these clinical symptoms, at the same time the persistent of hypoxemia despite the supplemental oxygen. At the same time, if the patient is tolerating the NIV and we have removed the NIV and the patient is tolerating without any assistance of assisted breathing, then there is no role, I mean like we can discontinue the NIV without any weaning period. Now, if the patient is on the NIV support, if there is a respiratory distress, we have the score that is a hacker score, less than 5 or more than 5. If the patient is having a hacker score, if it is more than 5, that means there is a failure that indicates the patient has to go for the mechanical ventilation. There are many indications for the mechanical ventilation, such as the hemodynamic instability, unable to tolerate the NIV, and the post, like status post respiratory, and as well as the cardiac arrest, and life-threatening hypoxia and all. If we move forward, our overall, if you see, the thing is that the presence of the short-acting inhaled agonist is having the evidence of the C, and the use of the systemic steroids, evidence A, and use of the antibiotics, evidence B. At the same time, methylxanthines is the evidence B, and the presence of NIV is the evidence A. So at last, once you are going with all these things, there is a thing called the care bundle, COPD care bundle that has to be taken care of the emergency. The thing is, the care bundle is based on the admission and as well as the discharge. These are based on the BTS guidelines. If you see the care bundles on the admission, that is DOTS. We follow the DOTS mnemonic, that is the DOTS for the diagnose exacerbation as soon as possible, assessment of oxygen status as soon as possible within 30 minutes. If you are recognize the respiratory acidosis as soon as possible within 1 hour, and the treatment should be initiated within 4 hours, and the specialist care will be given by within 24 hours. Now we know that once you are admitted and you are planning for the discharge bundle includes the TAPS, that is technical assessment, that as we have discussed, and how is the treatment plan, and we have to go for the action plan during the exacerbation, and we have to make sure that patient has to be explained about the pulmonary rehabilitation and as well as the vaccinations, and the smoking cessation, and as well as the review follow-up in the next 2 weeks. So if the patient is admitted, and if you want to calculate the score of, the modality, there is a DCAF score, which is for in-hospital mortality score to predict the mortality in case of the ACOPD. So at last, once you have done, exacerbation has been managed, and the patient is about to discharge, then we have to go for the discharge criteria. We have to make sure that the patient has to be followed up within 4 weeks. Within 4 weeks, to assess the patient that to what is the medications what we have started at the emergency, we have to make sure that any change in the medications is required or not, and we have to make sure that second follow-up will be done by the 12 to 16 weeks. That is following up. So thank you so much. My overall the summary is diagnosing the exacerbation as soon as possible, should rule out the mimickers, oxygen therapy, bronchodilator therapy are the most important therapies, treat the respirant and ensure the follow-up and smoking cessation. And these are my references, and thank you so much.
Of COPD exacerbation nicely. I think we can take up 1 or 2 questions from the audience.
Any questions from the audience?
So what we were thinking to take after the exacerbations, all 3 are over, not talking.
Okay, ma'am.
And then have the question.
Okay.
Okay then.
Okay.
Right.
Thank you. I mean, like organic committee for giving such an opportunity. Thank you.
Thank you, sir. Now the next topic of discussion is the crashing asthmatic patient, pearls and pitfalls by Dr. Venkat Komataraju, sir. I request the chairpersons to please introduce the speaker.
Good morning, everybody. I will now introduce the next speaker, Dr. Venkat Komataraju. His introduction is the Emergency Medicine Training Program Director, Health Education, East Midlands of UK. He is also a Vice Chair, Quality and Safety Special Interest Group. And his basic interests are the emergency toxicology, medical education, healthcare quality and patient safety, major trauma and medical leadership. I think already we are slightly running out of the time, I think. We'll quickly start. And now I'll invite Dr. Venkat, and let us see how he is going to manage the crashing patient of bronchial asthma in the emergency department. It's now over to you, Dr. Venkat.
Well, when you can't breathe, nothing else matters. In the face of the crashing asthmatic patient, every decision is a breath of hope. And asthma is a storm between taking a breath and obstruction. And we as emergency physicians, in the face of this storm, are the calm in the chaos. And today I'm going to talk about 3 pearls, 3 pitfalls, 3 questions for you to think about when you go back home: how to manage the crashing asthmatic patient, and 3 take-home points. Now, I work in the UK. We see about 600 patients every day. 80% of our patients are over the age of 80. And 80% in the current scenario either present with flu A, flu B positive, pneumonia, exacerbation of COPD, or they are crashing asthmatic patients. So pearl number 1, when you're doing a presentation, don't rely on your PowerPoint. If you do that, you will crash. So pearl number 1 is manage the respiratory rate. The problem with asthmatics is they cannot exhale. Asthma is not an airway problem. It is a ventilatory problem. They take a long time to exhale. And if you have a high respiratory rate, you will shorten that time for exhalation. And as a result, there will be breath stacking, there will be hyperdynamic inflation, it will worsen the dyspnea, they will become tachypneic, they'll become anxious. So number 1 thing is you need to shorten the respiratory rate. And how are you going to do that? And my question is, do you use opiates? Do you use benzodiazepines? Or would you use dexmedetomidine? If you use benzodiazepines, you will kill the patient because it will suppress the respiratory drive, they will sedate, and it will kill the patient. So benzodiazepines are a no-no. Opiates are mother's milk for asthmatic patients. I use small doses of fentanyl. Asthmatic patients are anxious, not because they're actually anxious, because they're dyspneic and tachypneic, they become anxious. So if you reduce the respiratory rate, you will control everything. Dexmedetomidine is great, but it takes time to work. At least takes 45 minutes to work. And if a patient who is on dexmedetomidine improves, then for sure you can say it is a good clinical improvement because dexmedetomidine does not suppress the respiratory drive. So number 1 pearl, take care of the respiratory rate. So when you can't breathe, nothing else matters. Slow the breath, you save the lungs. So pearl number 1, lower the respiratory rate. And if you lower the respiratory rate, you give them more time to exhale. Also, you can manage the tidal volumes better. You can lower the dead space, and they blow out the CO2, and their work of breathing improves. So pearl number 1. Pearl number 2, yes, you can give bronchodilators, yes, you can give steroids, yes, you can give magnesium. But a crashing asthmatic patients, they have severe bronchoconstriction. And if you keep on giving bronchodilators, the problem is because of the severe bronchoconstriction, these bronchodilators won't actually reach the distal bronchioles. So you need to give them a small dose of adrenaline or epinephrine, either subcutaneous. If you're brave, you can give intramuscular, or you can titrate intravenous. You know, it's a non-selective beta agonist. It causes bronchodilation, it causes vasoconstriction, it increases the cardiac contractility, it raises the heart rate. In emergency medicine, we are taught A, B, and C. Anesthesia, they are taught A, B, and C. Emergency medicine is airway, breathing, circulation. Anesthesia is airway, biscuit, and coffee. But in the crashing asthmatic patient, you need to see B, C, and A. Breathing first, then circulation, and then the airway. Asthma is not an airway problem. It is a ventilatory problem. If you fiddle with the airway, you will kill the asthmatic patient. If you fiddle early. Permissive hypercapnia, sir, saves lives. That means you slow the respiratory rate, allow the CO2 to rise slowly. This prevents breath stacking, prevents hyperdynamic inflation, manages the airway pressures. If you have hyperdynamic inflation, airway pressures increase, they end up having a pneumothorax. If you have hyperdynamic inflation, you will reduce the venous return. It causes circulatory collapse, causes hemodynamic compromise, patient goes into cardiac arrest. If you have hyperdynamic inflation, patient will have right ventricular dysfunction and the pulmonary vascular hypertension. So you need to have permissive hypercapnia. It is your friend, not a foe. So 3 pearls: manage the respiratory rate, use epinephrine, and think about permissive hypercapnia. What are the pitfalls? Number 1, over-reliance on bronchodilators. You can use whatever bronchodilator you like. Salbutamol, albuterol, terbutaline was very popular during COVID time. But the problem is, if you give too much of bronchodilators, they result in tachyphylaxis. They result in hypokalemia. They will result in lactic acidosis. They will result in downregulation of the beta receptors. So don't give too much of bronchodilators. You can give some bronchodilators, you can give anticholinergic, but epinephrine is the key. You can use nebulized epinephrine. Now, I was working in a hospital about 7 or 8 years ago. I was the only emergency physician, and there used to be no ambulances allowed after 8 p.m., and I used to do a night shift 11 p.m. to 8 a.m. When I go in for 11 p.m. shift, there'll be about 30, 40 patients waiting to be seen. And there used to be an anesthetist who manages cardiac arrest in 2 of the rehabilitation wards. And at 3 a.m. in the morning, a lady walked in with saturations in the 60s, completely blue, CO2 very high, around 16, and she was in impending respiratory arrest. And I didn't have much choice other than using lots of nebulized adrenaline, because giving too much. Of course, I gave her steroids, magnesium, etc., etc. And then I called this anesthetist. I said, now this lady is in impending respiratory failure. I don't have a nurse who can manage. You have 2 options. Now, the good thing about anesthetists is they never work on their own. The moment somebody is crashing and you call the anesthetist, they always say, where is my operating department practitioner? They don't believe on anybody else handing them the tube. They always want an ODP next to them. Now, this guy said, I'm not going to intubate because I don't have an ODP. Well, I said, I can be your ODP, but if you try to intubate an asthmatic too early, you will kill them. So I gave him the choice. I said, let's do this. Let's not intubate. Let me not be your ODP, but we can't manage this lady anymore here. Now, the reason this lady landed on the front door is because she thought she was clever, or her husband thought he was clever. What he did, he called for the ambulance on one phone, and he called for a taxi on the other phone. Obviously, which arrives early? The taxi, because the average waiting time for an ambulance in the UK to reach a patient is 8 hours after you make a phone call. For CAT 2. The average time for a person to reach hospital from here, or from their house here, the problem is traffic. People get an ambulance, but they can't reach the hospital. There, they don't even get the ambulance because we are so busy. So this lady landed up because the taxi driver came sooner, and she landed up at the front door. So over-reliance on bronchodilators is not good. Neglecting secondary causes. Asthma is never a solo performer. There is something else which is in the way of an asthmatic patient crashing. It could be because of mucus plugging. It could be because they have secondary infection. It could be because they might have a pneumothorax. So if you're good in ultrasound, you could do bedside ultrasound, look for presence or absence of pneumothorax. You can do aggressive suctioning to remove the mucus. If you think they are at high risk, give them antibiotics. So think about secondary causes. If you don't think, it's a pitfall. Final pitfall is rushing to intubate. These asthmatic patients, they have problem with hyperdynamic inflation. They have problem with auto-PEEP. You cannot eliminate auto-PEEP. You can only minimize it. And because they have hyperdynamic inflation, they are anxious, they are tachypneic, there is increased intrathoracic pressure, there is fatigue of the respiratory muscles. These patients become hypoxic, they become encephalopathic, and they have impending respiratory failure. If somebody says, you need to intubate this asthmatic, your decision should be, if I decide to intubate an asthmatic, let me wait some more. Let me wait a little bit more, but not wait too long. So you need to know when you need to intubate the asthmatic patient, but not too early. Because these patients are hypoxic, they're hypercapnic, they're acidotic, and if you intubate them, you will end up causing increase in their morbidity and mortality because of ventilatory induced lung injury, barotrauma, etc. So when intubation in an asthmatic is the last resort, and it is not without risks. If you can ventilate an asthmatic patient well, that means the patient is not asthmatic. There's some other problem there. You should really not be able to ventilate them well, and you need to manage the ventilator strategies. That is beyond the scope of this lecture. Finally, ladies and gentlemen, our job is not just to treat the airway. It is to protect the patient's life one breath at a time. So asthma management is like conducting an orchestra. You need to be able to play the tune well, and you need to have multimodal treatment attacking the patient from all sides. So key takeaway points, 3 pearls, which I've given you, 3 pitfalls. But number 1 takeaway is you need to reverse the bronchoconstriction with whatever way you want to do it. And the way to do that is because you reduce the work of breathing, you give them time to exhale, and you prevent impending respiratory failure. So reverse bronchoconstriction. Number 2, do not rush to intubate the asthmatic. And if you decide that you are going to intubate, which is only to buy time, you don't treat an asthmatic by intubating them. You only buy time whilst to keep them alive when the other therapies work. And 3, if at all you need to intubate, then you need to optimize the pre-intubation management. So ladies and gentlemen, asthma is a dangerous disease. It can kill people. And there are lots of people who have died because of people being able not really to manage asthma very well. So I hope in the last 15 minutes, I've given you some pearls and pitfalls and take-home points for you to manage a crashing asthmatic patient well. Thank you very much.
Thank you, Dr. Venkat. I think it was just like listening to a visual poem, nice visual poem. So, 1 minute, is it okay? So it's nice that it reminded us of the bronchial asthma over decades, all the time focusing on the exacerbation or a severe asthma. So we used to call it as status asthmaticus, there's near fatal asthma, then acute severe asthma. And nicely you have brought out into one word that ultimately the purpose is to manage a crashing asthmatic in emergency department. That means the ultimate aim of managing these patients by all of us. And it reminds me of two things that you reminded me of giving epinephrine by Hurst method. We used to give it by subcutaneously. And thanks that you have again reminded that nowadays people think that why you are giving epinephrine. The other thing is that you said that think about the other causes. This is the most important thing, that even though he's a known asthmatic on treatment, being optimized about it, and the patient is not responding and coming as a crashing asthmatic to the emergency department, we do think about the other causes. Is it asthma or something else? And just it could be an angina or the other day we have a patient who had triple vessel disease because the patient was not responding and he's in emergency, he crashed into the emergency. Just the only thing is listen to the history. For any patient, I think his story will tell us everything in spite of all the gadgets. I think that's my comment about it and conclusion. And once again, thank you. It's a nice poem. Thank you very much.
Thank you, sir. Now, moving on to the next topic. The chairperson for the topic is Dr. Vishwareddy Ma'am, Consultant of Emergency Medicine in Apollo Hospitals. The next topic being the pre-hospital pathways in exacerbation, do's and don'ts. Speaker Dr. S.K. Saif Iqbal sir, HOT Emergency Medicine, Critical Care Medicine, Ekashila Hospital, Hanmakunda. I request the chairperson to please kindly introduce the speaker. And the chairperson Dr. Kiran Kumar sir, Senior Physician, Consultant and Emergency Medicine in Yashoda Hospital, Hyderabad.
Good morning, everyone. Respected chief guests, my dear colleagues, and all the students. It is my honor and privilege to introduce you today a well-known, renowned emergency physician whose contributions to the field of emergency medicine has significantly impacted patient lives and who was forefront in saving many lives in the contributing his work to the field of emergency medicine. We are fortunate to have with us Dr. Asif Iqbal sir, who is the head of Department of Emergency and Critical Care Medicine, Ekashila Hospitals, Hanamkonda. His areas of interest include mechanical ventilation, arterial blood gas analysis, management of shock, and community awareness. His achievements include, he was a past Vice President for Society of Emergency Medicine, Telangana. He was an MRChem UK examiner. He was an examiner, speaker, and faculty associated with SEMI. And he was a course director for basic life support, advanced cardiac life support, and trauma life support, and disaster life support. And he had achieved many awards in state chapters and national awards from SEMI. We welcome you, sir. Over to you.
Good morning, everybody. First of all, my heartfelt thanks to the chair for such a good introduction, the organizing committee for today, my dear senior colleagues and friends. I'm thankful for this opportunity. We'll be discussing now regarding pathways for an exacerbation management, that is in a pre-hospital scenario. I thought it's a general medical emergency, pre-hospital, which could be easy for me. Then I went looking more into the topic. I thought respiratory emergency, very good. It will be a little bit easier for me. Then it was clearly written, then it is only exacerbation. So for an exacerbation, what are the pathways for a pre-hospital scenario? Now this became a nightmare for me because I was doing a lot of research wherein there was very, very less data available, especially within our country. There is a very poor data of what is happening for this particular scenario and what we are doing. So what I tried to do was, I tried to give you a reality picture on how it is going to be, some basic textbook information that how we have been told to follow, what are the realities that we are having in our country with respect to these guidelines, the checklists, the gaps in the literature, and how do we overcome by forming some bundles of care kind of thing for the EMS. We should not forget that most of the ambulances in our hospitals are taken care by the emergency paramedics, not by the emergency physicians. So we should think from their perspective, okay? So just a picture for you. What do you think? This patient. Is this patient in respiratory distress? This could be a call you could get from your emergency paramedic that we have reached the field spot and there is a patient lying, and obviously with the available smartphones, he can relay this picture to you. You being a doctor, now it's your responsibility. What do you feel? Patient is lying in a normal position. He is having open eyes, right? Maybe some grimace. So could be, could not be. Don't know. So what do we do now? You ask them to upsize the scene. Whatever scene is available, this is, don't forget, this is a pre-hospital field where the paramedic has reached. So you ask him to upsize the scene. What is upsizing the scene? Getting more information with respect to the environment available there. Okay, the patient appears that he can talk, so try to talk to him. So ask him to get a closer picture. Now what do you see? There is a peculiar pattern, post-breathing pattern, okay? This suggests of the patient is in distress. What is breathing? We all know it helps in improving exhalation. It helps in removing the carbon dioxide. So this patient could be a chronic airway disease patient. He is definitely in distress. Now, getting little bit more information. Asking him to sit up. See, he's in a tripod position, taking support of his knee. With the help of the weight, he is trying to breathe out. So that is suggestive of the patient is in more respiratory distress. So this patient needs a little bit aggressive intervention. In the meanwhile, what happened? The patient has collapsed. Now it's a headache for you. Now you got to follow all the BLS, ACLS protocols. Even this could be a scenario. All of these are possible in a pre-hospital area. So upsizing the scene is taking more help of the environment, availability of data, any medicines, any things which are surrounding the patient, which are going to give you more information about the acuity and severity of the condition. Obviously, look at the position, color, mental status. In any exacerbations, asthma, COPD, mental status is a very important indicator. Any decrease in the mental status is suggestive of patient is having a ventilation issue. He has to be aggressively managed. Ability to speak, you all know, if he is able to speak, he is having breathing efforts. If he is not able, then there is a problem with his breathing. Respiratory efforts by examination, by taking a video, EMS personnel can relay it to you, with which you can figure out what are his respiratory efforts. Cyanosis or clinical signs, not going much into it. Once cyanosis is present, it's suggestive of an hypoxia. You have to deal aggressively. Open the airways if the patient is unresponsive or semi-conscious. Look for any noisy breathing and or the characteristic type of breaths. How many breaths he is taking? The information should be given by the paramedic or the emergency physician to consulting in the ED. Signs of circulation like skin turn, dryness, the volume of these pulses. This basic information could be translated to the ED. Mental status already told. The basic vital signs using a simple pulse oximeter, a beat apparatus in the ambulance or at the site can pass on few basic vital informations which can give you an idea about the severity of this particular exacerbation. As importantly, sir told, history taking. You follow a sample format, OPQRST format, whatever, all this should give you patient information. Patient information with respect to his history. This will give you an idea about the rapidity of progression, the severity of how you have to attend him. Obviously about the cough, whether it's infectious, non-infectious, how long it has been, what has resulted in the present trigger. All this will give you an idea about any add-ons the patient has got along with just an exacerbation of asthma or COPD. Associated complaints, most important, chest pain. Most of the exacerbations can be an MI. So cardiac history has to be taken, any fever chills to rule out infections, wheezing to rule out his past history, smoking history, any trauma, because even a patient who has slept, has had a fall, can come with a pneumothorax, and he can also have a hemothorax, and he can have a wheeze. He can have a wheeze. We have seen most of the patients, because of the effusion, the lung collapse, they presented with wheeze. So wheeze always is not just a respiratory disease, it could be because of the effusion. So take a brief history of trauma, look for any contusions if you're not getting any other relevant information. All this history you take, medication, any patient is on previous oxygen, antibiotics, steroids, inhalers, cardiac drugs, that will help you getting more information. So for any respiratory emergencies, the basics are: what is the cause, what could be the pathology, what are the presenting signs and symptoms which give you the dynamicity of the present issue, how you are going to approach this particular management. So they tend to differ. This is the basic slide with respect to emphysema. Most of the speakers have told what is the pathophysiology, underlying basic problem, what are the chief complaints that can help you take him towards emphysema. Management, one thing I want, in emphysema, most of the patients, they are used for using inhalers, self-management techniques. So once they are on self-management techniques, there can be a delay in informing you. So we have to properly advise them. They will call you and they will tell, I am a known patient, I have been using these inhalers, and should I add another puff, should I add another inhaler? So you can give them advice, but make sure that it is not delaying the patient's arrival. So this is an important point with respect to management. Always correct hypoxia, which we will be discussing in the next slides. Hydration is a very, very important, because any asthmatic patient is a hyperdynamic patient. There are more insensible losses. There is more risk of dehydration, which can result in shock and other sequences with respect to cardiorespiratory failures. Asthma, basics are there. I just want to focus on other slides. For a paramedic, it is difficult to appreciate bronchi, especially fine bronchi, especially silent chest. When there is a silent chest, I don't think a paramedic can pick up. So he needs to have an awareness about there is a scenario called silent chest in an asthmatic patient. So if he is not able to pick up any breath sound, there is a possibility of silent chest, which can be the worst thing, which can tell that it's a crashing patient. You have to be more aggressive with this patient. Yeah, management. Respiratory failure, so there can be a problem with ventilation. The patient collapses finally with whatever it is, can result in all these conditions and can go for cardiac arrest. You may have to intubate the patient on site. You may have to start his ACLS, BLS protocols. Just few basic questions, just to waken up, because we are getting delayed with our coffee break. So you are in a restaurant where there is a middle-aged man at next table, begins to act strangely while eating steak. He appears to be in acute respiratory distress, but is completely silent. His eyes are open wide. He is staggering about. As you approach him, he slumps into your arms, becomes unconscious. What could this be? What could this be? Foreign body aspiration. Looking at the scenario, it could be very well by a foreign body aspiration. What do? Come on, very basic questions. B, attempt BLS maneuvers. I just go back. The patient has collapsed in your arms. So once the patient has collapsed in your arms, the basic Heimlich's maneuver, the patient has to cough out. Remember, when the patient has collapsed, there is no Heimlich's maneuver. You got to go ahead with your CPR. You lay him flat, go ahead with your CPR. If he has not collapsed, if he has a cough, then you go ahead with your Heimlich's maneuver. Second question, A 56-year-old man, chief complaint is dyspnea. Worse within a few days, the man is heavy set, BP, heart rate, respiration, tachypnea, saturation is 88%. What do you think? There is a progression of cough for a few days. There is a change in color of sputum, tachypnea. Answer is acute infection, chronic bronchitis, right? What do? In an ambulance, pre-hospital, apply oxygen. Apply oxygen is a basic thing. Stabilize the airway, then you give whatever your protocols do say. Next. A 24-year-old woman with difficult breathing, she is sitting up, bending forward, her chest is not moving much, she is so short, she takes inhalers daily, so she is used to it. What is wrong now? This is a pure acute asthma attack. So in this scenario, you give oxygen followed by inhaler, that is their bronchodilators or whatever. The last question. You are called to a restaurant to attend a patient respiratory distress. Speaking hoarsely tells you his respiratory distress is increasing. His respiration and wheezings are shallow. What is wrong with this patient? He had a shrimp cocktail. This is an allergic reaction, possibility of an allergic reaction. So what you should be doing is epinephrine. So just to tell you, exacerbations can be anything in a pre-hospital scenario. You need to have a basic experience of it. So this is an exacerbation, that is a downward spiral, how exacerbation events result in another exacerbation, another event, another exacerbation, finally results in multi-organ failure and death. This is some idea of lack of pre-hospital data. We have so much data for COPD management in hospital, in ward, in ICU, at discharge. But when it comes to pre-hospital care, when it comes to ambulance care, when it comes to ED, unfortunately we lack data. We just rely upon some small sample studies. But we should not forget that COPD is one of the important causes which comes to emergency and also in a pre-hospital area. So this is what we expect ideally the ambulance should do when there is an exacerbation. There is a acuity assessment, clinical history taking, initiation of process, emergency management, oxygen delivery, proper treatment, transport to definitive care, communication to ED staff, handover. So this is the ideal thing what we expect the ambulance or a pre-hospital care would be doing in a COPD exacerbation. But this is a real life scenario. This is a real life scenario in the rural setups. This is the ambulance what we have. And that is the personnel what we have who pass on the information to you. We have to accept it. Most of the hospitals, most of the ambulances, they are nothing but delivering vehicles or transporting vehicles with a driver and a cleaner. Slowly, yes, we are moving forward. Now we are coming up with advanced ambulances where there are paramedics who are trained, but still we have to go a long, long way. So why we have to go a long way? See, Kelly et al., ANSEM study 2008, they say 65% of COPD patients present to ED engaged ambulance service. So this is the brunt of load what our ambulances may get. 12th most common ED presenting resulting in hospital admission. 5th most common cause for a long stay or overnight stay is your COPD. There are so many challenges faced already by the emergency health because it's a confusing condition. It's not a clear-cut condition like a MI. So what is important is acute and timely differentiation of COPD exacerbation from other illnesses. But in pre-hospital settings, remember, it becomes very difficult, especially with lack of trained personnel, lack of quality EMS personnel, it becomes difficult. A recent Australian retrospective study by Williams et al., paramedics had a difficulty differentiating COPD and other conditions. They could correctly identify 57% of COPD patients, but even amongst them, finally in the hospital, 21% had a cardiac cause. So this is the amount of knowledge or level of knowledge what the paramedic level or pre-hospital level we are having as of now. These findings are corroborated by a US study where 30% had a discharge diagnosis unrelated to the intrinsic respiratory disease. So this is the level of knowledge what the pre-hospital services have. To add to all this problem, remember most of the COPD patients are older. They may have other comorbidities. which may require complex management. All this making an exacerbation or an episode of COPD more complex, more difficult, confusing. So our paramedics, they lose the confidence and they do not tend to go for it. So how to ease things? See, we have made it a 3-step scenario. First is to train them for the accuracy of diagnosis with respiratory distress. Tell them applying oxygen is good for any COPD exacerbation. Strategies to reduce COPD patients' requirements for pre-hospital services. That is by advising them to take proper bronchodilator or proper visiting of respiratory consultations. This may reduce the pre-hospital or ambulance usage for these COPD patients. Add a medical specialist in your ambulance, an emergency physician or a respiratory physician or a general physician with experience. If he is present with the team of ambulance, yes, definitely that will take good. So this has been proven by a study done on Denmark, which shows 469 patients admitted to hospital, correct diagnosis of COPD was made in 436 patients, so 92% of patients. So the presence of an emergency physician in your ambulance or pre-hospital care set makes a difference. Next important thing, telehealth services. All of us had got the smartphones, so use of your phones, passage of the Reliant data, making these data to collaborate with your ED doctor, take into loop your specialist physician, chest physician, transfer this data to them, take their advice and try to manage things. Maybe these type of a closed loop tele initiatives are going to improve the standards of healthcare for these type of exacerbations. Pre-hospital oxygen delivery, there has been enough spoken. Be liberal in giving oxygen. Oxygen will never kill you a patient. What myth we had, oxygen will induce hypercapnia, has now become a bedtime story. The facts for this are, hypoxic drive is more dangerous, ventilation perfusion mismatch improves with oxygen supply, Haldane effect has already been explained by the previous speaker. So give oxygen to any exacerbation patient, make sure the saturations are maintained at least 88 to 92%. Accurate diagnosis, expansion of pneumothorax, and availability of suitable equipment and trained staff. These three should help you in usage of NIV in your ambulance because it's a promising one. Use of NIV in any asthma patient early should be the important, important point in your protocol, standard protocol. Hensel and student, a recent study in Germany demonstrated that NIV applied by emergency physicians in the pre-hospital setting rapidly normalized disturbed vital functions in COPD patients, cardiopulmonary edema. ABG, enough spoken, type 1 respiratory failure. Once type 2 respiratory failure, think about the acidosis. Don't treat ABG. Don't treat numbers. Correlate with your patients. Correlate with patients' mental status. Always don't look at the PCO2. In a COPD patient, PCO2 will be high. Correlate that PCO2 with pH. That is very important. So once pH starts dropping, that is a crash scenario. That is a more dire emergency. Systems of care, yes, it's always been there. Patient experiences you have to take when they have traveled in emergency services. Alternative patient flow models you have to strategize. Try to improve the patient care. Make some guidelines for your staff by which they can adhere and they can follow certain protocols. Always, as the latest update, machine learning and use of artificial intelligence may help in managing these pathways well. It is now, that particular chart to the right is a management model adopted by one of the Australian study investigated. See how beautifully they have given it to the paramedics. What are the parameters to do, how to do a checklist, and when they have to gather this information and pass on this information to the relevant consultant in the ED, so that they pass on their knowledge and treatment guidelines to them. So these are some type of protocols what we can design indigenously within the available resources what we have can be passed on to our paramedics. So concluding, these are the pathways. Initial assessment by a paramedic, DRS, ABCDE, you all know. Monitor observations, take the vitals, respiratory rate, oxygen saturation, primary, secondary surveys. Then once goes to ED, it's already discussed there what happens. Confirm of COPD, once confirmation is there, take a brief history, action plan to be initiated with the help of the information what you get from the consultant. Acute management is by oxygen delivery first step, then whatever, your bronchodilators, adrenaline, whatever comes to picture. And use of NIV, I would add, use of NIV in an ambulance or pre-hospital setup. So these are some gaps in the literature. Diagnostic difficulties, getting confused with cardiac problem or pneumothorax, or is it really an asthma? This is always a challenge. So we need to collect more information, more data in our kind of setups so that we come up with facing these type of diagnostic difficulties. A myth, oxygen delivery should be ruled out. Oxygen should be judiciously given. The target should be to maintain the saturation levels of 88 to 92%. Strategies to reduce emergency presentation, that is by giving a proper handover, proper information, qualitative research with respect to this particular scenario, and computation of the data and auditing the same. Emergency department, epidemiology, we need to know of these patients, how they are outcoming. ED adherence to diagnostic and treatment guidelines, alternative ED units and care facilities, machine learning, and make it a loop. See, the information so far in the research what we have is starts from in-hospital. So we want that to start from pre-hospital scenario. What exactly is happening? How the patient is being transported in an ambulance? What are the problems that are coming in the ambulance? How the patient is reaching to the ED? What are the problems occurring in the ED? What is the management happening there? What is the outcome there? Then obviously in hospital we have so much. So these three links we are missing. So our research should focus upon these three things that will help us make a proper pathway for managing these exacerbations in the future. This is about artificial learning. Yes, it's always great. There are some evidence to show that this artificial learning, use of 5G ambulance, transferring of data, all these have helped in better outcome of your patients. So yes, it's a special.
So that is one thing. Then telemedicine should be available for the normal people as well, not only for the medical fraternity. It is for the common public as well. They are the end users. If we are going to use among users, what is the benefit to the common public? So it doesn't help much. If though they are having telemedicine, it should be accessible to the common public. Then only it will help us. It serves the purpose. That is one thing with service at home. Then there are artificial integrated CCTVs where they could detect chest pain, then breathing difficulty, respiratory distress. Same thing will be transferred to the local hospitals. So there are many CCTVs which are integrated with artificial intelligence now. So if we embrace those kind of technologies, we give the better services for the community, that is at a home level. Then when it comes to the pre-hospital setup, then we need to embrace the technology like 5G ambulances. So where we could see the patient live vitals and all, then we could deliver the, what are the things we want to tell. We want to convey the messages like how to assess the patient, what are the medication to be given, what are the contraindication of particular drug, then what could be the differential diagnosis, forget about the final diagnosis, probable diagnosis at least. Then these are the things. If we give that information to our paramedics, those are assisting with the patients, so it could make the difference a lot, what I feel. Then when it comes to the emergency, yes, we are all there. So where I feel the lag is like one is at home, another one is pre-hospital services. If you are going to fill those two gaps, definitely we are going to enjoy the platinum era of emergency. Then we could render the better services for the community. That is what my take. So as Asif sir told, then there are pathways regarding pre-hospital emergency services like a COPD exacerbation and all. So this we need to work it on it. Thank you, Asif sir.
Thank you, sir. It was very well summarized lecture. For students and for educational purpose, I just want to summarize the gist of it, what actually is the do's, and the topic itself is as such as do's and don'ts of pre-hospital care pathways. So till now we have many lectures pertaining to the emergency management. So what sir was telling to provide as a pre-hospital paramedics should be trained, which include emphasis on the history taking. Mainly the existing literature says that accuracy in the diagnosis, the narrowing down the diagnosis, that the dyspnea as such corresponds to COPD exacerbation. So narrowing down the diagnosis of and accuracy in the diagnosis of the COPD exacerbation, applying the mnemonic, that is DRS and ABCDE, history taking, as our senior physicians were telling here. Next, coming to the initial management pathways, that is the existing literature says pertaining to limits to use of bronchodilators, and also inadvertent use of steroids as such is not indicated. Only stat dose of steroids is indicated. And as sir has already told that there is a paucity of literature, existing literature and studies pertaining to the use of NIV. NIV as such can be used by the paramedics. There are mortality benefit as per few studies as done in the Germany, but few Canadian studies say that there is no mortality benefit. Maybe future research should be done pertaining to the more NIV use in the pre-hospital. I'm not talking about the emergency department. And intubation as such should be deferred because there will be hyperdynamic circulation and atopy. So just following this simple pathway would aid stabilization of the patient, delivering adequate oxygen therapy, and avoiding use of high concentration oxygen as it would lead to CO2 retention, and early detection by an early use of NIV would benefit the purpose. Thank you, sir.
Not wasting your time. So there is one second. I just want to add one point. Madam is available here. We can get this data with the respect to pre-hospital care, madam, only by having a capacity building program for the paramedics, which I don't think we have focused yet on. We have very limited emergency physicians so far, and with the brunt of load in the emergency departments and number of corporates coming up, it's difficult for the emergency physician to go. Maybe we can have a program wherein emergency paramedics numbers can be increased and can have association with the emergency physicians and these programs so that the teamwork forms and can have better quality standards to do all these things in future.
Thank you so much. This is a very important point, sir, which you have focused upon. So I I should tell this now, that there are 8 states in the country which run BSc paramedic course. And Telangana Nizam Institute is one of them. Though Kaloji University, we have written a letter, we have written mails to them multiple times. We have attached the existing BSc program curriculum, the mails. So I see a lot of senior people. We are in Warangal. We are in the place where Kaloji University is. We request anyone who has a say into it to please initiate the BSc EM technology program. It is already available at various universities. The curriculum is running. And every medical college for start, we have 710 medical colleges now in this country. So every medical college should have, even if not PG students to start with, because the newer ones cannot start till they are 5 years of their establishment. They can always start paramedic course. And just to show our conviction of training paramedics, we have got 2 of our trainee students over here. So Akhil and Shiva. So they are training with us in BSc, and just to make sure that you see them as well, and they see us as well, we brought them along with us. So thank you so much. Please, senior people are here. Do help us to start this program across the state of Telangana through Kaloji University.
Definitely, madam. So we too have discussed with Kaloji University people. That's why they have given affiliation of to start the emergency medicine. So the emergency medicine started in the government institutions, first at Kakatiya Medical College. So in par with them, we can also, as these paramedic technicians who should be handy with the doctors, should also be taken away. With your help, we will approach the university people. So definitely we are with you, madam. And be help us in how to put the documents and all. Definitely.
Yes, sir. The curriculum I'll share, sir. Definitely, all the curriculums I'll share.
Thank you.
Thank you, sir.
Over to you, organize.
Thank you, sir. Thank you, ma'am. Now we will have a presentation of mementos by Dr. Shiva Subramaniam, sir, to Dr. Rahul Rohan, sir. Now I request Dr. Satish Chandra, sir, to present memento to Dr. Venkat Komatraju, sir. Thank you, sir. Now I request Dr. Kiran Kumar Varma K, sir, and Dr. Vishwareddy ma'am to present a memento to Dr. S.K. Asif Iqbal, sir. Thank you, ma'am. Thank you, sir. Now I request Dr. Ashima ma'am and Dr. V. Chandrasekhar, sir, to present mementos to chairpersons. I request Dr. Shiva Subramaniam, sir, to please come out to the dais. Thank you, sir. Now I request Dr. Satish Chandra, sir, to please come on to the dais. Thank you, sir. Now I request Dr. Kiran Kumar Varma K, sir, and Dr. Vishwareddy ma'am to please come on to the dais. Thank you, sir. Thank you, ma'am. into the ED and take away our sleeps for days together and even throughout the rest of our cares. The next presentation is about the refractory hypoxic patient on the mechanical ventilator by Dr. Mayank Dir sir. And the chairperson for it is Dr. Shravan sir. Shravan sir is Associate Professor in Anesthesia in Mahabad Medical College. And I invite Dr. Mayank Dir sir, Associate Professor, Department of Emergency Medicine, MNR Medical College, Hyderabad. I request the chairperson to please introduce the speaker, sir.
Yeah, thank you for this opportunity. Thank you, organizers. I should express my gratitude for few persons for making me to sit in front of all of you, and not only in front of all of you, but in front of so many of my teachers, mentors, and also stalwarts of this place. So Dr. Ashima Madam was my teacher. So when I was doing my MD anesthesia at Nizams, and Dr. Chandrasekhar sir has been a mentor and a guide even when I was a house surgeon here at KMC. So it's very nice moment in my career to chair this session, having given opportunity by them. So now the topic is so the refractory hypoxic patient on mechanical ventilator. So you attach a patient to a ventilator, but you'll not be achieving your goals to maintain normoxia, sometimes normocapnia, and associated hemodynamic perturbations. So probably Dr. Mayank Dir will enlighten us what to be done, what not to be done when the patient is on mechanical ventilator and getting exposed or witnessing a situation where his oxygen saturations or PO2s are not improving. So Dr. Mayank Dir is an associate professor at MNR Medical College, and his areas of interest are high altitude medicine, pain management, and also mass casualty management. And he has done his MD DNB, and he has got a publication, Impact of Surgical Mass Placement over HFNC on Oxygenation Parameters in COVID-19 Patients, and has been promoted as Associate Professor and could complete 5 official timed half marathons. So that is very important for maintaining a physical fitness. So I would now welcome Dr. Mayank Dir to proceed with this lecture. Thank you.
Good morning, everyone. Slide changer. Slide changer. Maybe Tishi pattern. తీసుకుంటాను సార్ స్లైడ్ కావట్లేదు.
All right. Hi, good morning, everyone. Sorry for the glitch. So here we have a 70-year-old male, Mr. Pushparaj, known diabetic, hypertension, IHD, LVF, was admitted in severe respiratory distress and put on a mechanical ventilator. patient who had been stabilized suddenly now becomes restless and agitated on the ventilator. He's sweating, he's tachycardic, his saturation is dropping. What do you think should be done next? Anyone? So this is what should be done next. I'm here, I'm Mayank. I'm an associate professor working in Department of Emergency Medicine, and I'm here to guide you through by troubleshooting the ventilatory graphics, by looking at these scalars, loops, and trying to save Mr. Pushparaj from dying. So that's me. And so the basic indications for when you put a patient on a ventilator for intubating are different from those which you need indications for putting the patient on mechanical ventilation, right? So you can sum them up into an increased airway, change in lung compliances, hypoventilation, a VQ mismatch, an intrapulmonary shunting, or a diffusion defect. So what does a mechanical ventilator do? A mechanical ventilator is a useful modality for patients who are unable to sustain the level of ventilation necessary to maintain the gas exchange, functions of oxygenation and carbon dioxide elimination, right? So this is, okay, so Mr. Pushpa has changed to Mrs. Pushpa. You are a first year resident. Anyone who's a first year resident here? Right. Your saturation starts dropping down this patient. Your senior who's just helped you intubate this patient has just walked out for a cup of coffee. What do you think should be done? Anyone, any first year would want to answer this? All right. So the major problems can possibly that either Pushpa is chewing on her endotracheal tube, or possibly the tube is getting kinked, or the tube is a very small size tube, or there might be some mucus plug, or this might be a right bronchial intubation. Now these might, or there might be a water in the circuit. Having trouble with changing this. All right, or it might be an equipment failure. The mechanical ventilator might not be working. There might be an airway in the circuit. This slide must be a little nostalgic. Is this nostalgic to anyone? Not the left one. So the message is don't get doped, but always remember the mnemonic DOPE. So D stands for displacement. Okay, so this might be a displacement of the endotracheal tube, or it might be a right bronchial intubation. It might be getting kinked. It might be obstructed. While fiddling with the airway, you would have caused a pneumothorax, or there might be an equipment failure or an esophageal intubation. So the message is clear. Don't get doped, but always remember the mnemonic DOPE. Right? This is post-year intubation when you're first year resident. So your patient's desaturating. All what you need to do is disconnect the ventilator. If you are really not, if you're a rookie with the venti, just disconnect it. Switch on the patient to a bag and mask ventilation and just look for any relief. If you're having a relief, then good. If not, then again get back to your ABCs. So now you see that there is some relief. There's an airway obstruction. Yes, pass on the suction catheter, check if there's any obstruction, check if she's biting the tube, check suction and try to clear off the secretions. If you have a relief, then yes, it was an obstruction. If not, then think of the respiratory cause, think of the cardiac causes. Respiratory cause, try to listen, you have any rhonchi, you have newer secretions which have come, or it's a right-sided bronchial intubation, it might be a pneumothorax which would have caused. Look for, get a troponins, do a point of care ultrasound, check for any new arrhythmias which have developed, check if the patient has got a massive MI, check if the patient's having a P. So these are main things what you need to think of if your patient, just whom you have intubated, is not doing well. So now, my topic here today is to just tell you about what to do on a mechanical ventilator, right? So mechanical ventilator, you have spontaneous mechanical modes, you have volume and pressure targeted. So why do you need this pulmonary mechanics? So think of how an ECG is to cardiology. Similarly, your ventilatory graphs, that's your scalars and loops, are to that of a ventilator. So you'll be able to troubleshoot only once you're able to recognize these loops and graphs. So a broad picture of mechanical ventilation, the scalars can be, you have 4 measured parameters. That's your flow, time and volume, which are measured against the time. So these are the flow, time and volume scalars, and you have your pressure volume loops and your flow volume loops. So how does this all begin? There's a trigger, that's a stimulus which starts to the flow of gases. You have delivery of flow, that's inspiratory flow, the cycle and the expiratory phase. These are the 4 phases of a mechanical breath. So anyone, any first year, which mode of ventilation put Mr. Pushpa on? What do you think? Which mode is this? Pardon? All right. So this is a volume control mode of ventilation. Right. So the volume control mode of ventilation, again, everything what we have to do is with the scalars and loops. What you can see here, up is a pressure time scalar. Below you have a volume time scalar. Is this visible? This is a flow time scalar, this is a pressure time scalar, and this is a volume time scalar. So everything on scalars, you have a flow time, pressure time, and volume time. So the column 1 denotes a flow time scalar where your inspiratory waveform, which is above the baseline, can either be a square wave, or it can be a sine wave, it can be an accelerating or a decelerating flow. And when you have your column 2 here, you have your pressure time scalar, in which if I would apply an inspiratory pause, this is the diagram which I would achieve. I'll talk about that in the next slide. All right, so loops, pressure volume and flow volume. So this is how you get your flow volume loop. The process of inspiration starts here. You achieve your peak inspiratory flow rate, the inspiration, and then you achieve your tidal volume here. And then is where your expiration starts, where you have your peak expiratory flow rate. Now, the components of a pressure volume loop would be that you have your volume on your y-axis, your pressure on your x-axis. You have an inspiration, you reach your peak expiratory pressures, and then your tidal volume is generated. So this is what about the pressure volume loop. So I'm just talking about these basics because that will help us troubleshoot of what you want to see in the next coming slides. Right? So these are the different waveforms, and inspiratory and expiratory, what you would see in a controlled versus assisted versus a spontaneous mode. So this diamond, which should not be usually, you should not be seeing it. This indicates that there's an auto peeping or the patient's work of breathing is increased. So this is the main crux of the volume control mode of a flow time scalar. This is the process of inspiration. I did tell you that this is a square wave pattern what you achieve. So you have your two limbs, that's your inspiratory and expiratory. As soon as the inspiration starts, you achieve your peak inflammatory flow rates, then there's a plateau. So here there's the limb, your inspiratory valve closes. So then when your expiratory valve opens, you have your beginning of the inspiration. Now this graph, this is the same schematic representation of the initial ventilatory graph which I showed you to begin with, when I asked you which mode do you think this patient is on. So this is the same schematic representation of that ventilatory picture. Now this is a pressure time scalar, flow time scalar. So a pressure time scalar, when I've applied a inspiratory pause, that is, this is a peak pressure, when I've applied an inspiratory pause, that is when there is no flow, you have your plateau pressures which you achieve. And this is the flow time scalar which you achieve, which I've already spoken about in the previous slide. Right? So what is the component of inflation pressure? This is the same which I was talking about earlier as the pressure time scalar. You have your initial sharp rise, that is because of the resistance which it has to overcome from your tubings, right? Then you have a gradual slope, which is the resistance which it comes over through the lungs. And then when I would apply a inspiratory pause, you would get a plateau pressure here, which is denoting basically your compliance of the lung. And all this part was denoting your resistance of the lung, right? And then when you have your expiration, then there is where you get the decelerating waveform. So just to differentiate between a volume time and a pressure time, it's very clear. In a volume time ventilation, you have your volume which is preset and the pressure is variable. And a pressure control, you have your pressure which is preset and the volume is variable, which is shown in the top right, left hand of my slide, the differences, right? And now same thing, a schematic representation of what it looks like on a graphic, you would have a flow time scalar, which will be in a volume control mode, you'll have a flow time scalar because the flow is preset, the volume is preset. Contrary, in a pressure time, you'll have a decelerating waveform. Here, you have initially a sharp rise, which gradually lessens in a pressure time scalar, but because in a pressure controlled mode, you have a pressure which is preset, that's the reason why you're having a square. So remember, square is always for the preset in a volume targeted volume ventilation versus a pressure targeted ventilation, right? So now why did I tell you all this basics is to basically understand the pathophysiology. So anything what Venkat sir spoke about, the asthmatic patient, or like Rahul spoke about your COPD crashing patient or a ARDS patient, everything eventually if you're able to get the scalars and loops, you'll be able to identify them. So first cause, possibly an air trapping or auto peep. right? So it might be because of an insufficient expiratory time or an early collapse of the unstable airway. So how do you think this looks like? Now this is a flow time scalar. You have your inspiratory wave and your expiratory wave. So this is normal. This is a dotted line which is normal. You see your expiratory wave which is reaching the baseline. However, if you have an air trapping which is occurring, you see that the expiratory form never reaches the baseline, right? So this is an auto peep which is generated. So what do you think? How would you troubleshoot an auto peep, which Sir did mention on the non-invasive ventilations? If you have a ventilator, you would give a bronchodilatory therapy. Now, if you see a bronchodilatory therapy, you see again, this was before. You have a elongated time and your PFR, your peak expiratory flow rates were never reaching down. However, when you have given a bronchodilatory therapy, you have your peak expiratory rate which have increased now. So this is how you identify on a ventilator if you're doing the right thing or not, right? Now this is about air trapping on a flow volume loop. So this would be a normal pattern. This is a normal inspiratory and expiratory. You see the cycle is completing and it's reaching the baseline. However, if you have an air trapping, how do you diagnose on a flow volume loop is? You see that this never hits the baseline, right? So just to recap, what an air trapping, how would you diagnose it on a flow time scalar is the flow never reaches the baseline, and here in an air trapping, the volume never reaches the baseline. Are we clear with this? Great. So now, how do you fix it? You give treatment, do a bronchodilatory therapy. If you have an auto peep which you've generated, just disconnect the ventilator. Second, you can increase your tidal volume, increase the mechanical minute ventilation, or adjust your IE times, increase the expiratory time, right? And avoid adding peeps in asthmatics because it might cause a pneumothorax. What about airway resistance? So airway resistance be caused because of a bronchospasm, a small tube, a king tube, or there's a lot of airway resistance, or a secretion which is being built up in the endotracheal tube, or there's water in the HME filter. So how do you see this on a pressure time scalar? You see this is a normal, this is what I told you, right? Inspiratory pause, your PEEP and plateaus being achieved. Now think if there's an increased airway resistance. Same Pushpa who's having a small tube or she's kinking on the tube, you might have an increased airway resistance because I told you that in the previous slide that your peak pressures will indicate an increased airway resistance. So this is how you see, this should be the flow time scalar on a patient who's having an increased airway resistance. Now what do you see on a flow volume loop? Now you see this is a normal, the one indicated in the white is a normal, your inspiratory and expiratory which is reaching the baseline, but you have a scooped out pattern if you see that there's increased airway resistance. Right? So if you see something like this, then you need to ensure that you need to, the resistance is more and you need to troubleshoot the same. Okay. Airway secretions, if there's water in the circuit, this is what you would see like on a flow time scalar. This is a recap of increased airway resistance on a flow time scale, on a pressure time scalar, and these are the your flow volume loops. This is how you will get a scooped out pattern in case of an increased airway resistance. So what do you do when you have an increased airway resistance? You need to give treatment, you need to possibly get a bigger size tube, you need to suction that mucus plug which was blocking the airway, or possibly you need to give adequate bronchodilatory therapy, you drain the water, change the EPI filter, change the endotracheal tube, add a bite block, and change the expiratory filter if this you're not able to get. Now imagine compliance as simple as blowing a balloon. So the more the balloon can blow, that indicates the compliance, so that you think it's similar to that of your 5 minutes more, right? To your lung, right? And the opposite would be elastance. So what happens, so I'll try to speeden up with my slides. Compliance, you have change in volume per unit, change in unit pressure. This similar graph which I mentioned to you earlier, the peak pressures and the plateau pressures when you're applying an inspiratory hold. But yeah, this is basically the crux of compliance. So you see that gradually as you begin the inspiration, you have your airway resistance, if you have your peak pressures which are going up, and once you would apply an inspiratory pause, you would have the compliance. So your compliance might be going up here if you are treating a patient with an ARDS. So I'll just try to speeden up the graphics which are coming. But again, think of, if you have an increased compliance, you can think of these differentials like ARDS, atelectasis, abdominal distension, CHF, consolidation, fibrosis, a pneumothorax or a pleural effusion. as an increased compliance, you will see either a emphysema or a surfactant therapy. So these are differentials for your static compliance and your dynamic compliance. Now, decreased compliance on a pressure time scalar. You see your peak pressures have gone up. Now, if it's an ARDS lung which you're trying to ventilate, your peak pressures are anyways going to go up, but the compliance also going to rise. So now here your peak versus the plateau, the difference has reduced here in comparison to that of an airway resistance where we had an increased difference between the peak and the P plat, right? So just to sum up, an example for an increased airway resistance where your difference are more. This is a patient with an ARDS lung whose peak and P plat, the difference is less, right? So this would be an example for conditions which are causing an increased compliance. The same, how would you look like on a pressure time? This is how it look like on a PV volume loop. That's a pressure volume loop. Your tile volumes on your y-axis and your pressures on your x-axis. Now here you have your volumes which are fixed. So with the poorly compliant lung, the graph is going to shift towards the right. Now, how about in a pressure time? Now, what do you see on a pressure controlled ventilation? So the pressure is fixed. That's on your x-axis. And so here, if you have your poorly compliant lung, you see your graph which is dipping down. So the area indicated in red is your poorly compliant lung. So you see that the compliance is dipping down. So a recap of all the compliances and increased compliance, how it looks like on a pressure time scalar and how it looks like on a pressure volume loop. So each time you have your patient either desaturates or your patient goes hanky-panky, ensure that you have to check for your compliance, that if your compliance hasn't worsened, there's a new onset of ARDS or the ARDS is worsening or not. So always ensure that you have your plateau pressures checked each time a patient desaturates. Now the last part is the leaks. You have an expiratory leak or an inspiratory leak. TT cough, chest tube, a BP fistula, and NG tube can be causes of an expiratory leak. A loose connection, a ventilatory malfunction, or a faulty sensor can be causes of an inspiratory leak. Now, how does it look like on a volume time scalar? What all goes in doesn't come out. So you again have in the expiratory valve, this never touches the baseline. And same thing, what it looks like on a flow volume loop would be this never gets to the baseline, right? So this is how you detect that there's a leak of the patient. Same thing on a air leak on a pressure volume loop, you have your inspiratory part and your expiratory part, but this never touches the baseline. So this is how you detect an air leak. How do you fix it? Check for all possible causes listed, do a leak test, make sure all the connections are tight. Now, this was one of my patients whom we were treating with ARDS. Is this slide visible? No, I don't think so, but anyways. So one of our patients which we were treating for ARDS, so the problem with the compliance. So you would want to give lesser tidal volumes, higher PEEP for such a patient. So what do? First, calculate the predicted body weight. Start this patient on 8 ml per kg of idle body weight, tidal volume. Get the PEEP to around 0 to 5 ideally. Target a saturation of around 88% and above to around 95%. And then check for your plateau pressures. If your plateau pressures are high, they're about 30. How you can do that is just look at your flow time scalars and your graphs. If it's high, you need to get down on your tidal volumes. Do it 1 ml per kg for 2 hours, then recheck. You can go as low as 4 ml per kg of tidal body weight and keep simultaneously increasing the PEEP, right? And this is the ARDS-NET criteria which you can follow. You can have this on your ventilators when you're trying to see a patient with ARDS. Now, what's the best strategy? What helps is basically proning. So I'll just tell you in brief, how does this proning work? So you see this patient who's lying down supine, and you see this patient who's lying down prone, right? So just read with me and look at the diagram. When you prone the patient, the blood flow is unchanged. Blood flow in the dorsal region is unchanged. So all this region which is in the red, you see that that's your dorsal area. Here, this was your dorsal area, and here, this is your dorsal area. This is unchanged, right? So when you're flipping the patient, the dorsal area is still unchanged. The blood flow is better there. And however, when you flip the patient, the pulmonary edema and the lung weight will now move to a newly dependent lung. So now here you see your alveoli which were collapsed here when the patient was ventral. Now they start opening up when you have actually flipped the patient around, right? You see all these small alveoli which are opening up. So, and also proning will not put the weight on the heart. So this, again, the same patient, eventually he was still hypoxic after doing all these things. So maybe on day 5, day 6, we did a Doppler, we got a DVT. Then we did, like Rahul said, always get a POCUS done. We got a CTPA done. We could see a major filling defect here in your left main bronchus, left pulmonary artery, and then we plan to do a thrombolysis for this patient. That's, the point here to just put is that P is always a masquerader, and when you don't think it's usually there around, and your RB-LV ratios, which were 0.7, and eventually this patient was thrombolized. So that's it. I guess I'm on time. Thank you so much. Thank you so much.
So that was a nice lecture, Dr. Mayank. Really, it is a difficult topic to explain management of a patient with refractory hypoxia on ventilator. It's really a very difficult topic to explain through ventilator graphics. I feel he has done a commendable job.
Thank you, sir.
Explaining the flow volume loops and also the pressure time, flow time curves and all. And the emphasis he has given on the P peak, P alveolar pressures and lung protection strategies is also a very important thing, because most of the times we connect the patient and we try to forget the lung protection strategies and titration of the tidal volume, P, FiO2s and all to maintain the normal PaO2s. What exact PaO2, what is your goal PaO2 and what is your goal SpO2? So these are the important things. And not only looking at the causes or etiology from the lungs, you also have to look what are the etiologies which could be outside the lung, like it could be a cardiogenic shock, or it could be LV failure which is causing a pulmonary edema and causing the decrease in the lung, what you call as alveolar compliance. So all those causes you have to do, and you also, very importantly, has mentioned about the equipment factors and also the small subtle things in ICUs which most often will be ignored, like leaks or HME filter or simple secretions in the tube or accumulation or condensation of water within the expiratory and also the inspiratory limb of the ventilatory circuitry. And a kink could cause much damage, because sometimes the patient can be agitated, he might not be properly sedated, or all the time we may not paralyze the patient in order to maintain the endurance of the lung and also to wean the patient early from the ventilator in order to avoid a ventilatory dependency. So on the whole, I feel he has done a good job. Thank you.
Thank you, sir. Now I request Dr. Ashima ma'am to please come on to the dais to chair the topic of pulmonary embolism arrest. And speaker Dr. Gunasilan sir, Assistant Professor, Department of Emergency Medicine, SMB Pondicherry. And I request the chairperson to please kindly introduce the speaker.
So, yeah, have a seat now, please. So, it is my pleasure and honor to introduce Dr. Gunasilan. So, my memory is not very good, but if I correctly remember, and I also checked in my phone, it was 13 December, 5 p.m. in the evening when I met, in 2019, when I first met Dr. Gunasilan. And why I met him was I went as an examiner to JIPMER, and my flight was from Hyderabad to Chennai. And I was told by the head of department of JIPMER that one of my senior residents who is doing that day a workshop with Dr. Dhawapalani sir at Chennai, another big man in the field of emergency medicine, is doing a workshop, and he's attending that. And so after attending his workshop, as your flight will also reach, he'll bring you to Pondicherry. So we were talking. I am known for, I talk. And we connected during our, cab. And he told me that I have some 500 ECGs. So truly speaking, at that time, Dr. Guna, I felt, okay, it's like every day we also have so many ECGs coming to our emergency. But the passion in Dr. Gunasilan was something which, caught me And it stuck to me. So he said to me that when your exam is over, ma'am, I will come and show few of them. And then he thought, okay, maybe she's not believing. So he told me there is I don't know whether he remembers, but he told me that there is a patient who came to us and he had J waves, remember? So knowing that it was hypothermia as a reason why he was not waking up was something which was very commendable. And today, after counting 5 years, 5 years plus few days, I'm so happy that I could get you your time to come and talk on such an important CME happening and respiratory emergencies. Needless to say, he's presently working, his bio is there available there, but see, you see where his publications are. They are in circulation journal. Just check it on. What is how to enter circulation journal? Not easy. You will agree with me. We have been at Nizam's doing publications right and left. JAMA, not easy. So with all due respect and thank you for giving your time, I welcome you, Dr. Gunaseelan. Please come.
So, thank you for the wonderful introduction, ma'am. It's a pleasure and an honor to be invited to be at faculty at this conference. I thank you and as well as the organizing person. So, without wasting time, we'll move on to the topic per se. This is pulmonary embolism and cardiac arrest during a pulmonary embolism and how to manage a patient with cardiac arrest during a pulmonary embolism. So, if you want to get these slides, you can scan this and get these slides. My slides are always available for everyone. At the end of this lecture, we are going to learn 4 things. Okay, one is how to integrate focus during a cardiac arrest. What are the modifications that we are going to do when we identify that this patient is having probably a PE during ACLS or during cardiac arrest? Okay. So this is the learning objective for this. So we'll see a patient. This is Miss Priya. She has underwent a knee surgery 3 weeks back, and now she has presented to us with breathlessness. Her left leg is slightly swollen, okay, and she has discomfort also over there. So what could be the probable diagnosis for this patient? Yes, most likely pulmonary embolism. The topic also aligns with that. So what are the other possible diagnoses? So whenever we are in the emergency department, don't just have one eye, okay? You also have an open mind to look at the other possible differential diagnosis. What are the other possible differential diagnoses this patient can have? Yes? DVT, yes. DVT, pulmonary embolism, venous thromboembolic phenomenon. We are looking at that as one possible thing. Anything else? Cellulitis, sepsis, septic shock, okay, surgery was there, infection. Okay, so all these can be a possibility. Okay, so we'll move on. So this patient was visibly distressed and she's diaphoretic. She is tachycardic, her blood pressure is low, her oxygen saturation is also low. And as you are trying to stabilize this patient suddenly becomes unresponsive. Okay, so what do you do when you hear the term unresponsive? After rigorous trainings of BLS and ACLS, the moment you hear unresponsive, yes, okay. Tap the patient's shoulder, check for response, call for help, check pulse and breathing, and activate. Yes. So that is what this team has done. Activate code blue. Okay. So this is what is called as a pit crew approach to a cardiac arrest scenario. Okay. So what is this pit crew approach? This is famously adopted from Formula 1 race. Okay. How long it takes somebody to change a wheel of a car? General. How long will it take for you to change a car wheel? Huh? You don't do that? Okay. Yes, roughly half an hour to 1 hour. Okay, but in Formula 1, how long does they take to change a car's tire? Less than 10 seconds, 4 seconds. 2.3 is the world record, 2.3 seconds. They change 4 wheels, not single wheel, all the 4 wheels of a car. Okay, how is this possible for them? Yes, repeated training and teamwork. Okay, all the principles of your team dynamics, they know their roles, they know their limitations, they all have their backup. So I found this article very interesting, but I had only one problem here. Okay, that is the person at the foot end. Okay, does it really need to be boss? No. Okay, so boss and leader, there are different concepts between them. It's better to have the term leader. Okay, so for managing this patient, is these people enough? We have 2 people on the CPR, 1 person to assist with the airway and 1 person to manage the airway, 1 person for IV/IO access and a leader. Yes? Are these people enough? Some more is needed. Yes, Sarah was telling some more. So what are those some more? Okay. Focus being an integral part of emergency medicine, and to identify all those reversible causes like cardiac tamponade, pulmonary embolism, we need definitely a person to do the focus. Anybody, 1 person to do an ABG or to send some immediate labs, and 1 more person to get history from the patient. As from the morning everyone was telling, history is also an important tool to look at the diagnosis or the clue. Okay. So what are their roles? The person doing CPR has to do the CPR. The person managing the airway will manage the airway as per the ACLS. And the remaining person's role is to identify the reversible causes, that is 5 H's and 5 T's. So here we have a history, and we are going to confirm your pulmonary embolism diagnosis. How are we going to confirm our pulmonary diagnosis? By focus. Okay. This patient is truly in cardiac arrest or not? Should we find out that? Yes. How many people are very confident that they will be able to identify a pulse, or they'll be able to identify that the patient doesn't have pulse during a cardiac arrest within that 10 seconds? Yes. How many of you are very confident that I will be 100% sure that yes, Mayank is telling me, 100% sure that this madam is telling? Okay. So we look into the literature. So this is a study done in 1996. Okay. What they did was they took some paramedics and some of the emergency medicine technicians to cardiac OT, where the patient was put on a cardiopulmonary bypass. So these patients will not have pulse, obviously, right? And they asked them to check the patient's pulse, blinded. Okay, they didn't tell that whether this patient was on bypass or off bypass, and they asked them to check at their carotid pulse. Okay, and they found out the sample size was 206 participants. Okay, remember this. And they found out that only 10% of the participants thought there was a pulse when there wasn't. Okay, and 45% of the participants thought there wasn't a pulse when there was one. And average time to make those decisions was 24 seconds. And within 10 seconds, only 17% of the participants were able to identify correctly whether there was a pulse or not. Okay, so 17% means only 35 participants out of the 206. This study still remains very valid. So we need to integrate focus to identify whether the patient is truly in cardiac arrest or not. Okay, so what is the image showing here? Yes, the cardiac standstill. Okay, the heart is not beating very clearly, right? What is the image? VF, ventricular fibrillation, right? Okay, yes. So sometimes this can look like a flat line in the ECG, in the monitor, or sometimes you will get a that is called a pseudo PA. Okay, that is what we are trying to discuss here. What a pseudo PA is, you will have a pulse, but you will not be able to appreciate that pulse, and you will label that as a pulseless electrical activity. Okay, so it is better to use these two terms instead of PA or others. Okay, because we are going to integrate focus into our assessment of cardiac arrest. Okay, so pulseless with rhythm and echocardiographic standstill, that is a true PA. Okay, or true asystole or true cardiac arrest. Whereas in some patients they can have pulseless, but they will have a rhythm and they will also have an echocardiographic motion. Okay, these patients may need interventions like defibrillation or some other thing. The other reason we integrate focus during a cardiac arrest is to identify reversible causes. Okay, so this is the ACEP guidelines on how to integrate focus during cardiac arrest. what they ask us to do is, you prepare the machine. At the time when we do the pass for the pulse check, the 10-second pass, you put the probe and get a recording of the image. Don't try to interpret the image at that 10-second time. Put the probe, get a recording, okay, and then resume CPR. Restart CPR. At that point of time, you review the cardiac activity, okay, what exactly is happening, and then you intervene based on those. Okay, the most problematic area why many people ask us not to use POCUS during a cardiac arrest is it prolongs the interruptions. Okay, that is why ACEP has given clear recommendation that don't try to interpret the POCUS image during the pause. Okay, get a recording and then interpret during the CPR time. Okay, so that's why we need to have a dedicated person for the POCUS. Okay, yes. So of course, during a cardiac arrest, your heart will not beat. But if you see these two images, okay, the RA and RV is dilated, or you see a visible thrombi in the right atrium or the right ventricle. Does your diagnosis confirm now? Is it pulmonary embolism? Yes. Okay. So there are various other echocardiographic signs, but during a cardiac arrest, you will be able to see only two. One is an RA-RV dilatation. Another is a visible thrombus or an hyperechoic mass in the RA and RV. Okay. So once you have identified, next what you are going to do? The leader, he has identified. Next what he is going to do? He is going to order the person to give a medication. Okay. So this is called as a peri-arrest thrombolysis. So we are going to give thrombolysis during the cardiac arrest itself. Okay. What is the standard drug dosage for pulmonary embolism if the patient is not in a cardiac arrest? 100 mg altiplase over 2 hours. Okay. Any other drugs that we give? Streptokinase we can give. Streptokinase have various regimens, low dose, ultra low dose, and normal dose. Okay. The recommended dose during a cardiac arrest is altiplase 50 mg IV bolus. Okay. This is the only FDA approved drug for peri-arrest thrombolysis in a case of pulmonary embolism. Okay. So you give 50 mg IV bolus. You can repeat the dose if you are not getting any ROSC even after 15 minutes of CPR. Okay. So the dose is 50 mg IV. You have to push it as a bolus. Okay. The other drugs which are still under study are, one is retiplase 20 units IV bolus, another is tenecteplase 0.5 mg per kg IV bolus. Again, these are areas or avenues for young PGs to focus on research. Okay, that is why I have put those two things. The next thing is, should we stop CPR early in this patient? Okay, we'll look at the airway. Next thing is airway. So when you are treating a PE patient, a suspected PE or a confirmed PE patient, try to avoid intubation. From morning, many people were telling this. Okay, try to avoid intubation. Okay, intubate as a last resort. Why we are trying to avoid intubation is, what does intubation do for a patient? It increases their, you are giving positive pressure, right? So it is increasing their intrathoracic pressure. So it is decreasing their venous return. Okay, and in pulmonary embolism patient, their RV preload will be significantly reduced, and it can cause more harm than good. Okay, but you have already intubated the patient, so take advantage of that. What we can do? We can administer pulmonary vasodilators through the endotracheal tube. Okay, we can give nitric oxide. How many of you have a Boyle's apparatus in your emergency department? If you want to give nitric oxide, you have to use a Boyle's apparatus, right? So this is a good pitch for your emergency department to the management that we need a Boyle's apparatus. We need to administer pulmonary vasodilators, not only for pulmonary embolism. There is next talk will be on a pulmonary artery hypertension. A crashing pulmonary artery hypertension patient may also require inhaled pulmonary vasodilators. Okay, yes. The other drugs may not be available, but if nothing is available, give 100% FiO2. Okay, 100% FiO2 is otherwise called as a poor person's pulmonary vasodilator. Okay. Yes. And then what about CPR? We are going to extend the CPR for a long time. Okay, don't stop the CPR at 20 minutes or 25 minutes, because we need to give some time for the thrombolytics to circulate and work. So extend the CPR for more than 60 to 90 minutes. This may seem little far-fetched, but if you have more people, or if you have a mechanical CPR device, okay, you can do this, and consider advanced techniques like ECMO, okay, eCPR. Okay, so the European Society of Cardiology recommends ECMO to be considered only when you have facility for either a surgical embolectomy or a catheter-directed thrombolysis, okay, in a crashing pulmonary embolism patient. Again, this is also a low quality of evidence, level 2B evidence only. This is the current only recommendation for considering an ECMO or an eCPR during cardiac arrest. Yeah. So in summary, use POCUS as well as history judiciously to find out the reversible causes. Okay, administer thrombolytics if you suspect PE and if you diagnose PE during a cardiac arrest, administer thrombolytics. The recommended drug is Altiplase 50 mg. Extend the CPR for more than the usual time, that is to 60 or 90 minutes. Avoid intubation. If intubated, try to administer inhaled vasodilators, pulmonary vasodilators. Okay, and consider ECMO CPR or eCPR available. Yes, thank you. So for those, I'll put the slides QR code back again. If you want to have scanned it, you can have. Yeah.
Thank you, sir.
Any questions from the postgraduates or the audience?
What we were thinking was to finish all the 3 talks and then put up the questions, so that, thank you so much, means there is no doubt it was so easy to understand and follow it. And I have to move down because I want to scan it properly before this slide goes off. Just keep it for me, 1 second.
Thank you, ma'am. Thank you, sir. Now, the next topic of discussion is the hypoxic hypotensive patient of pulmonary artery hypertension. The speaker is Dr. Anusha SS ma'am, Assistant Professor, Department of Emergency Medicine, SPMCH, Tamil Nadu. The chairperson is Dr. Rahul Rohan sir, Assistant Professor, Department of Emergency Medicine, NIMS, Hyderabad. I request the chairperson to please kindly introduce speaker.
I welcome Dr. Anusha, ma'am. She completed her MD Emergency Medicine from JIPMER, and she also did the DNB Emergency Medicine. And presently, she is working in Swami Vivekananda Medical College as an assistant professor in the Department of Emergency Medicine. Our areas of interest is trauma, resuscitation, and point of care ultrasound, critical care, and as well as the toxicology. And her achievements, she published 2 original articles, original research, and 10 case reports in the Index Journal. And she is the instructor for the BLS, ACLS, and as well as the ATLS. And she is involved in quality improvement initiates in the emergency department. And I welcome Dr. Anusha ma'am to continue forward the session. Thank you.
So good afternoon, everyone. So now I'm here to discuss the topic on the hypoxic and hypotensive patient of PAH. It is one among the most difficult group of patients to handle with, if I'm not wrong. So in the next 15 to 20 minutes, we'll try to discuss how we are going to manage a hypoxic and hypotensive patient. So the agenda will be like, first we'll discuss what is pulmonary hypertension, what is the pathophysiology, and we are going to discuss something which is very terrible, that is the RV spiral of death, and the 3 key pathologic forces which are driving the spiral, and how we are going to approach a patient with a failing RV. So what is a pulmonary hypertension? Basically, it is a pathophysiologic disorder, and it may involve multiple clinical conditions. Many cardiovascular diseases can be associated with pulmonary hypertension, and recently they have changed the definition of pulmonary hypertension. Previously, it was a mean pulmonary artery pressure of more than 25 millimeters of mercury at rest, which was being called as pulmonary hypertension, and now it has been reduced and it is more than 20 millimeters of mercury. So we have clinical classification. There are 5 groups. Group 1 is the pulmonary arterial hypertension. Group 2 is the PH which is associated with left heart disease. In group 3, we have pulmonary hypertension which is associated with the lung disease. And group 4, we have the PH which is associated with pulmonary artery obstructions. And PH group 5, we have unclear or multifactorial mechanisms. And we have classification which is based on the physiological basis also, that is the pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension, and combined pre- and post-capillary pulmonary hypertension, which is based on the pulmonary capillary wedge pressure and pulmonary vascular resistance. In the pre-capillary group, you can see that the pulmonary capillary wedge pressure is less or equal to 15 millimeters of mercury, whereas pulmonary vascular resistance is more than 2 Woods unit. Here again, the definition has been recently changed. Previously, it was more than 3 Woods unit, which was resistance. In the post-capillary pH group, you can see that the pulmonary capillary wedge pressure is more and the pulmonary vascular resistance is less, in which you have the group 2, that is, which is due to the left heart disease. Group 5, we have etiologies from multiple groups. So that has got both increased pulmonary capillary wedge pressure as well as increased pulmonary vascular resistance. So what is the basic pathophysiology behind the PAH? So one is like there is a decreased pulmonary vascular compliance which is causing the increase in total pulmonary vascular resistance. And when your pulmonary vascular resistance goes up, what happens to the mean pulmonary artery pressure? It goes high. And when there is a increase in the mean pulmonary artery pressure, what happens to the RV afterload? RV afterload is increased, and which is causing the RV to work more and more. And there is right ventricular pulmonary arterial uncoupling, which is causing both the hypoxia as well as hypotension. So end stage, we have a decreased cardiac output as well as there is a decrease in the mean pulmonary artery pressure. You can see that as the stage goes on, the pulmonary vascular resistance is increasing and the cardiac output slowly declines. So going to the case scenario, there is a 55-year-old male who is a known case of pulmonary artery hypertension due to idiopathic etiology. He is presenting to your ED with a 24-hour history of progressive dyspnea at rest, fatigue, and lightheadedness. This indicates that the patient is having some acute decompensation, right? It's a very sudden onset. And he reports intermittent chest discomfort, denies any palpitations. He has got poor adherence to his medications. He was on some pulmonary vasodilators, which he has stopped taking. And his baseline oxygen requirement was around 4 liters per minute at nasal cannula, which he was receiving at home. And he was on a continuous intravenous ipoprostenol infusion. So on arrival to your ED, you're finding that the patient is tachycardic, hypotensive, tachypneic, and hypoxic. On physical examination, you have central cyanosis, JVP is elevated, you're able to hear loud P2 heart sound, bilateral lower limb edema. There is no significant crackles or wheezing on auscultating the lung. So probably, what are we dealing with? An acute decompensation of a PAH patient, acute RV failure that we are dealing with. So how are we going to manage this patient? So before going to the management of this patient, I want you to learn some basic physiologies behind this PAH or RV failure. So what we are going to discuss is the right ventricular spiral of death. If you see, the starting point is the increased RV afterload. What is this due to? There is an increased pulmonary hypertension. The mean pulmonary artery pressures are high. When the mean pulmonary artery pressures are high, the RV has to pump against the pulmonary artery pressures. So the RV afterload is high. So that is what is the starting point of this spiral of death. So initially the RV is going to face a pressure overload. When mean pulmonary artery pressures are high, the RV is facing a pressure overload, and slowly the RV starts to decompensate. When pressures are high, your RV starts dilating. It gets hypertrophied after a long time. It takes time to adapt, and there is an increased RV volume. So what are the two problems that the RV is going to face? First is the pressure overload. The second is the volume overload. So why is RV different from LV? So have you managed LV failure patients? Is it same as managing an RV failure patient? No. Why is RV different from LV? Basically, pulmonary circulation is a low pressure, low resistance circuit. Okay. RV is actually very thin-walled. it is less muscular, it is more compliant, and it actually works against a less resistance. Your systemic vascular resistance, comparing with the systemic vascular resistance, your pulmonary vascular resistance is 1/10 lesser. Okay, it works against such a low resistance circuit. Suddenly, if your pulmonary pressures go high, pulmonary artery pressures go high, the RV doesn't adapt to that and it doesn't work that well. So it is more dependent on volume loading than the pressure to accomplish the work of the ventricle. And RV doesn't adapt well to the acute changes. The RV is perfused in diastole as well as systole. We all know that the LV is perfused only in diastole, but the RV's perfusion is occurring both during diastole as well as systole. So RV's response to increased afterload. So when there is an increased afterload, you would have learnt the Frank-Starling's mechanism, right? What is Frank-Starling's law? Can any of the PG tell? What happens? Yes, so the force of contraction is directly proportional to the end diastolic volume. So the end diastolic volume determines the stroke volume. When there is a more of end diastolic volume, the myocyte contraction, the force of contraction increases and the stroke volume also increases. But this doesn't work with the RV. So initially you can see that the cardiac output slowly increases with the volume status, but at one point of time in LV failure, it becomes a constant, whereas in RV failure, the cardiac output starts to drop down with your increase in volume. When there is an increased preload, volume means preload, with an increasing preload, RV starts to fail. So that is an important thing that we have to understand when we consider an RV failure. So you can see that the RV is much more sensitive to increase in the pressure, increase in the afterload than the LV. If you see the LV can maintain the stroke volume very well. When there is an increase in pressures like 100, 110, 120, the LV can maintain very well. Whereas RV, when there is a change in pressure of just 10 millimeters of mercury, from 20 to 30, there is a sudden drop in the stroke volume. So there is an increased RV afterload, there is an increased pulmonary vascular resistance. So the RV starts to dilate as well as it starts to hypertrophy. As it dilates and hypertrophies, what happens is there is a bowing of the interventricular septum into the LV. Okay, we'll try to understand it better. So there is a bowing of interventricular septum into the LV, which again, it will cause a reduction in the cardiac output because LV ka volume also becomes lesser. The LV end diastolic volume also becomes lesser when there is a bowing. As well as when RV dilates and hypertrophies, you can find that there is a distortion of the tricuspid valve and it leads to tricuspid regurgitation. So when there is a tricuspid regurgitation, again, the cardiac output is going to reduce. So this is what we're talking about, the bulging of interventricular septum. So there is something called ventricular interdependence. Usually the LV and RV function, they are both dependent on each other. You can find that the LV's preload is nothing but the RV's stroke volume. Whatever is going to be pumped out by the right ventricle is going okay, and it causes a D-shaped LV. So ultimately it reduces the cardiac output. So this is what we see in a parasternal short axis view in which we are able to find that there is a D sign. This is what we call it as a D sign. There is a bulging of interventricular septum into the left. So this is the RV and this is the LV. So what is RV ischemia? This is another important concept that you should be understanding. Towards going on to the graph, you can find that the graph on the top is aortic pressure curve. The graph on the bottom shows the right ventricular curve and the pulmonary artery curve. So what happens, as we have already discussed, RV is getting perfused both during diastole as well as systole. So the RCA perfusion, it decreases proportionally to increases in the right ventricular pressure. So when this right ventricular pressure goes up, okay, the pressure gradient between the aortic pressure and the right ventricular pressure comes down. Okay, this pressure gradient is what it drives the perfusion of the RV. So we have to maintain a pressure gradient so that the RV is getting perfused well. Okay, so when the RV pressures are so higher than the aortic pressures, obviously the RV will go for an ischemia. The perfusion will come down and RV will go for an ischemia. What happens when the RV goes for an ischemia? RV's contraction is going to reduce and again the failure is going to worsen. Okay. So as we have discussed, there are three key pathologic forces which are driving this RV spiral of death. One is the RV's response to the increased pulmonary vascular resistance. This we have already discussed. Like when there is an increased pulmonary vascular resistance, that is RV afterload, the Frank-Starling mechanism doesn't work and it starts to fail. The cardiac output comes down. Second is the RV pressure or volume overload, which is causing bowing of the interventricular septum, which again reduces the cardiac output. And the third is the RV ischemia. So again, coming back to the RV spiral of death, we started with increased RV afterload. Because of the increased RV afterload, there is an RV dilatation, tricuspid valve insufficiency, that is tricuspid regurgitation. So the RV wall tension increases. When there is an RV wall tension is increased, both the neurohumeral activation occurs as well as myocardial inflammation occurs. Ultimately, RV oxygen demand goes up, whereas oxygen supply comes down. So there is an intrapulmonary AV shunting, which we are discussing. RV, pulmonary arterial uncoupling occurs. RV goes for an ischemia, hypoxic injury. So RV contractility comes down. When RV contraction comes down, RV output comes down. When RV output is reduced, LV preload is reduced, ultimately leading to reduction in the cardiac output, reduction in the systemic blood pressure, reduction in the coronary perfusion of the RV. So RV oxygen delivery also comes down. So this is a vicious cycle which leads on to obstructive shock and death. So when we get a patient who is hypoxic and hypotensive, we are trying to better not let the patient into the circle, better not let the patient into the spiral, or if he's already in some point of the spiral, we want to try to bring him back out of the spiral. So how are we going to approach this patient? First, we are going to optimize the preload, optimize the contractility and afterload to the right heart. So as you see there, what are the points where we are going to focus is, first thing, we have to decrease the pulmonary vascular resistance. Why? That was the starting point. The pressure overload was the starting point for everything. So we want to decrease the pulmonary vascular resistance, one. Second, we have to optimize the preload. Understand the term optimization. We are not either decreasing the preload nor increasing the preload. We have to optimize the preload. Then we have to improve the contractility of the RV. And we have to increase the systemic blood pressure. Why do you want to increase the systemic blood pressure? As we discussed, RV ischemia occurs when RV pressures are higher than that of the aortic pressures. You want to maintain the aortic pressures higher, right? So systemic blood pressure should be maintained at a higher to ensure RV perfusion. So we have to increase the systemic blood pressure. So there are three factors, right? Pump, pipes, and tank. Okay, we have to optimize all these three. So first thing, what we are going to discuss is optimizing the lung. Hypoxia, hypercarbia, and acidosis. All these three are going to cause pulmonary vasoconstriction. So all these three can kill the patients. Pulmonary vasoconstriction is going to increase your pulmonary artery pressures. So what we have to do is, whenever you are finding a patient on patient with PAH with hypoxia, you have to deliver oxygen, liberal oxygen. Okay. So any oxygen delivery device to correct hypoxemia is fine. What is preferred is HFNC, high flow nasal cannula, by which you can deliver high flow and higher FiO2 if the patient is not on any like type 2 respiratory failure. If PCO2 is fine and if patient is not in any pulmonary edema, you can go with HFNC. If at all the patient is having hypercarbia and cardiogenic pulmonary edema, then non-invasive positive pressure ventilation. But again, as we have already discussed, what is going to happen when you are going to deliver a positive pressure ventilation to this patient? Again, it is going to increase the mean pulmonary artery pressures. Okay, mean airway pressure is going to raise. So better reserve it only when the patient is having hypercarbia or cardiogenic pulmonary edema, otherwise HFNC will do good. And whenever you're putting a patient on HFNC or NIPPV, you're going to do a close bedside monitoring, which is very, very important. You want to see whether the patient is improving or deteriorating, and you have to alter the management. And drainage of moderate or large pleural effusions can be done. Next is to talk about intubation. Already everyone has talked about intubation so much. Again, coming to the pulmonary artery hypertension also, it is going to be detrimental because you will give sedation while doing intubation. What happens when you give sedation? Most of the drugs will cause vasodilatation. So when there is a systemic vasodilatation, again, it is going to reduce the preload. When there is a sudden drop in the preload, everything is going to go bad. So, and when you sedate and the patient is going for a transient hypoxia or hypercapnia, again, the pulmonary vascular resistance is going to raise because of vasoconstriction. And positive pressure ventilation, it increases the pulmonary artery pressure and RV pressure. Excessive tidal volumes. When you give excessive tidal volumes, what happens is it compresses the intra-alveolar vessels. So again, it increases the pulmonary vascular resistance. So all these things are going to go bad when you are going to intubate the patient. So decision on intubation is very critical. You're going to delay it, you're going to avoid it, but when the patient is critically ill, when there is no other go, we are pushed to intubate rather than losing the patient. So what you can do when you're trying to intubate? First thing, you can consider cardiostable induction. So what do you understand by cardiostable induction? The drugs you are using. So etomidate can be tried or ketamine can be used. Ketamine, what is the positive point is, it keeps the respiratory drive also on. So your worry on hypercapnia also comes down. Or better go for an awake intubation. Okay. And considering pre-induction arterial line. Why is this important? You are expecting that the patient's pressures might go down, patient might go wrong when you are intubating. Okay. So you don't want to wait to tie a BP cuff, measure BP, then respond, react. Instead, if you have a pre-induction arterial line, you can act much more faster. So if time permits, you can consider a pre-induction arterial line, and you should always have your ready-to-go pressors. You know that push dose pressors are being used. One is push dose epinephrine, the other is push dose phenylephrine. Better not use phenylephrine. We'll discuss why. We can use push dose epinephrine and inhale nitric oxide. Again, Dr. Gunasilan sir had talked about this. So inhale nitric oxide, if we give, again, it helps in pulmonary vasodilatation. And how about the ventilation strategies? Always go for a low tidal volume because excessive tidal volume is going to cause compression of the intra-alveolar vessels, increased pulmonary vascular resistance. So go for a low tidal volume. Always target normoxia, normocapnia. There is no concept of permissive hypercapnia in case of pulmonary artery hypertension. And you have to limit the PEEP. You have to keep the plateau pressure less than 30 centimeters of water. Second, optimizing the volume status. So whether I can give fluids or not. Whenever a patient comes in to ED with hypotension, we tend to give fluids, right? So what is it going to do for this group of patients? So you have to optimize the preload. If the preload is really less, if the patient is hypovolemic, definitely we are going to give fluids, but given short, small aliquots of fluids, like 250 ml bolus, then see how the patient responds. If the patient is really hypovolemic, give fluids, otherwise not. Usually the diuresis helps more than fluid administration in case of a hypervolemic patient. So what we can do is, we can use CVP, central venous pressure, because it is going to measure your right-sided filling pressures. Ideally, the target can be maintained at 8 to 12 millimeters of mercury. If you find that the CVP is more than 12, then you can go for diuresis more confidently. So then establishing an adequate mean arterial pressure. As we have already discussed, this prevents the patient from RV ischemia. So it promotes adequate perfusion of RV myocardium. It perfuses the kidney. If at all needed, it allows for diuresis. So it increases the LV ka afterload. So when LV's afterload is increased, you can find that the bulging of interventricular septum may be brought back to the normal somewhat. So among patients with patent foramen ovale and left to right shunting, right to left shunting, again, if you raise the LV afterload, you can find that it may reduce the amount of shunting. So it is very essential to establish an adequate mean arterial pressure. So what do we understand by this adequate mean arterial pressure? What is our target? So optimal target is more than 65 millimeters of mercury. That is where you can start with. But if at all CVP is very high, then 60 millimeters of mercury plus CVP. That is what we are going to target, because MAP should be always higher than that of your right atrial pressures. So patients with systemic congestion and low MAP, patients whom you are finding that the patient is having a congestive features as well as the mean arterial pressure is low, you can do a combination of both. You can give vasoconstrictors, and on the other hand, you can give diuretics. So these are the different vasopressors which we can use. So vasopressin. So what is a good thing about vasopressin is like it increases the mean arterial pressure as well as it decreases the pulmonary vascular resistance. So it does good in both the ways. But what is the problem? It is very difficult to titrate. You can start at 0.01 to 0.06 units per minute and let it be there. But it might be insufficient as a single agent in a patient who is having a profound hypotension. You might need one more vasopressor to add on. And it is not safe for peripheral administration. You might need a central line. Epinephrine. Epinephrine, it acts as an inotrope at lower doses, vasopressor at higher doses. So it increases the MAP as well as it decreases the pulmonary vascular resistance. But the problem with epinephrine is like it might cause tachycardia, which these patients might not tolerate. The third drug is norepinephrine. So norepinephrine is a systemic vasoconstrictor, so it increases the MAP, but at higher doses, it can increase the pulmonary vascular resistance as well. So it is very commonly used. It is very easy to titrate, safe for peripheral administration. So the first drug of choice, you can choose norepinephrine, as well you can start vasopressin also. So how about phenylephrine? It is very much contraindicated in pulmonary hypertension patients because it has got a potent pulmonary vasoconstrictor effects. So what would be the ideal hemodynamic agent? The one that increases the cardiac output, which maintains the systemic vascular resistance, and that should decrease the pulmonary vascular resistance. But we might not have ideal agent always. So maybe you can start with a vasopressor, then you can add a inotrope. Why you want to add a vasopressor before starting an inotrope is like most of the inotropes like dobutamine and all, it can cause vasodilatation, which is not we are not happy with it. So better to start a vasopressor to achieve peripheral vasoconstriction, then add an inotrope. So when should you start inotropes? When there is a systolic failure of the right ventricle, inadequate systemic perfusion despite other measures, as well as when the patient is having bradycardia or inadequately low heart rate, like normocardia, whereas it is inappropriate for the clinical situation, then you can start on inotropes. So what are the inotropes? Dobutamine, milrinone, and epinephrine. So dobutamine, it can increase the cardiac output, but remember it can cause tachycardia as well as systemic vasodilation. So always start it along with a vasopressor, not as a single agent. Second thing is milrinone. Milrinone, again, it is a PDE3 inhibitor. It increases the cardiac contractility as well as it causes peripheral arterial and venous vasodilation. So it is similar to dobutamine. It should not be started as a single agent. It should be started along with a vasopressor. It has got role in decreasing the pulmonary vascular resistance as well. So epinephrine, it again increases the cardiac output. There is no systemic vasodilation, but always remember it can cause tachydysrhythmias, which is poorly tolerated in this group of patients. So this is to sum up with all the agents. First, you can consider the first three agents are mainly vasopressors. The next three are mainly inotropes. So as you see, vasopressin, it has got no role in cardiac output or it reduces the pulmonary vascular resistance and it increases the systemic vascular resistance. Norepinephrine, it has a potential to increase the pulmonary vascular resistance. Phenylephrine, definitely it increases the pulmonary vascular resistance. That's why it is contraindicated. Dobutamine, epinephrine, and milrinone, out of these three, all these are going to increase the cardiac output, whereas milrinone reduces the pulmonary vascular resistance more compared to the other two agents, and epinephrine has got, it increases the systemic vascular resistance as well. The next is heart rate and rhythm optimization. If at all this patient is having a tachydysrhythmia, what happens is, when the patient is having a tachycardia, what happens to the diastolic filling time? It reduces. So ultimately the cardiac output comes down. So if at all PAH patient is having a tachydysrhythmia, better immediately we should follow a rhythm control strategy. With a minimal sedation, we have to cardiovert the patients immediately. Then coming on to the pulmonary vasodilators, we were talking about the inhaled pulmonary vasodilators, that is inhaled nitric oxide and epoprostenol. So it is helpful in improving the oxygenation as well as improving the ventilation perfusion mismatch, as well as it reduces the pulmonary vascular resistance. So if as it reduces the pulmonary vascular resistance, it improves the RV failure. There is no systemic vasodilation or systemic hypoperfusion compared to the intravenous pulmonary vasodilators. So never we start intravenous pulmonary vasodilators in the ED. Usually we start inhaled. If at all patients are on intravenous pulmonary vasodilators, like as we saw in the case scenario which we discussed earlier, the patient was on an infusion of epoprostenol. If at all such patients come to your ED, you have to make sure that the continuous infusion is going on and there is no like any disruption in the line. So when do we start pulmonary vasodilators? Is it if the patient is in refractory hypoxemia, and when you want to stabilize the patient in the peri-intubation period, and when the RV failure patients with higher risk mortality are coming to you, and contraindication when the patient is having a severe left ventricular failure or pulmonary veno-occlusive disease, because it increases the congestion more. Then another important thing that you should always consider is you have to correct the precipitating factor. The patient was a known PAH, he was on drugs, recently had withdrawn like that. So the patient is coming to you with an acute decompensation, so you have to find out why the patient went in for an acute decompensation. So when that can happen, it can be because of indwelling line infection, pulmonary embolism. If you're suspecting pulmonary embolism, you have to treat the same. And it could be because of COPD exacerbation, pneumonia, interruption of the pulmonary vasodilator therapy, sepsis, hypovolemia, anemia. So you have to evaluate for the same and treat the same. Sepsis and pulmonary hypertension. So when you have pulmonary hypertension patient in sepsis, there occurs systemic vasodilation. So what happens again? The RV perfusion pressure comes down and RV cardiac output comes down. So in this group of patients, always consider broad spectrum antibiotics and start on vasopressors. Here again, norepinephrine is going to be your first line agent. And being the patient with pulmonary hypertension, they can always consider bowel bacteremia in this group of patients due to congestion and compromised intestinal barrier function. Lastly, a word on VA ECMO. So this is kind of a standalone treatment. If at all the patient is having hypoxia and hypotension due to PE, this can be a bridge to the catheter-directed lysis or surgical thrombectomy. So VA ECMO, it is going to support the systemic circulation, and it is going to reduce the RV preload, as well as it is going to offload the failing RV. So it is going to be of definite help, but problem is with the cost and availability. So the take-home points. So one is, you have to maintain a balance between your pulmonary and systemic pressures. You have to go down on the pulmonary pressures and you have to go high on the systemic pressures. So you have to be very judicious in the fluid resuscitation. So avoid positive pressure ventilation if at all possible. So aggressively identify and treat the underlying causes. Start broad spectrum antibiotics early if you are considering sepsis in this group of patients. So if at all the patient was on any vasodilator therapy, we have to continue the same without any interruptions. So for hemodynamic management, we can use epinephrine, norepinephrine or vasopressin along with inotropes. Tachycardia is poorly tolerated in this group of patients, so we have to treat the same. Intubation is a last resort. So if at all we are pushed to intubate, you can go for an awake intubation and always avoid prolonged apnea or oversedation. So CPR could be futile in this group of patients, and you can involve the pulmonary hypertension specialist early and transfer to the higher center. Thank you. So, any questions? Yes, ma'am. Actually, I was not aware of it. Just now, Najib was discussing it. Does a very great job in the subgroup of patients. So I think it would be better if Dr. Najib could put a word on how it works.
Actually, I mean, like we are doing a study on this inhaled nitroglycerin in emergency department with the patients with a PAH with a heart failure. So the same, it's like the same thing of inhaled nitric oxide, but the thing is that as we have discussed, as your presentation also showing that a temporary stabilization can be done at the point of time during the intubation. And as usually, we have to look for the precipitation, what is the precipitance of the pH and all. But if you are using the inhaled NTG, at least 15 to 20 minutes of the time, there will be hemodynamical stability will be achieved. We can able to see. And we have seen the patients who are all present, almost 20 to 25 patients we have seen. We can able to see the ABG and we can able to tell that this patient is having this sort of the thing. ABG findings, I still remember, pH with a 6.8 with a bicarb of 8. These will be standard things the patient will present to emergency with an history of this pH and all. We have supplied with we have supplemented inhaled nitroglycerin and there will be a drastic improvement. So during the intubation, this will be plays an important role. And we are we are on the verge of, we are doing the RCT on that. So we are continuing this study. At the same time, as Dr. Anusha ma'am discussed regarding the wonderful presentation on pH, that too with a hypoxic and as well as hypotensive. Both are, it is a killers. So the mesmerizing diaphragm, mesmerizing pathophysiology diagrams, which is the most important thing. And to summarize all of these things, I want everyone in the hall, the PGs and everyone, whenever you see, actually my teachers, Dr. Ashma ma'am always says that if you are a good physician, you know when to intubate. But if you are a better or a best physician, you must know when you should not intubate. So that is the most important thing. So all the students who are presented here, whenever you are seeing such type of a patients with a pH, with a hypoxic and as well as hypotensive patients, definitely will come across this thing in a point of a life. Always make sure that it is that first thing is pre-intubation, during the intubation, post-intubation, as ma'am discussed. Pre-intubation, always make sure that it is a physiologically difficult airway. You are labeled it as a physiologically difficult airway. That means you have to make sure that you have to call an expert. It should not be like you should not try on your whole self, you have to call an expert. That is the most important thing. And during pre-intubation, we have to make sure that, as ma'am discussed, a role of apneic oxygenations, either going with an HFNC or you are going with nasal cannula. That is the most important thing because already the patient is hypoxic. So when to start, how to start, that expert will come and the expert will have a role in case of this thing, pre-intubation. And the one more point to add, and during the intubation, as Dr. Anusha ma'am discussed, that is a role of the drugs. What drugs you are going to use, whether the sedative and as well as the paralytics, whether I have to go with a half dose or you have to go with double the dose of the paralytics. But if you are using with the sedatives, whether I have to go with etomidate or I have to go with the ketamine, because that will play an important role. And during the intubation, if it is better if you go with an inhaled NTG, at that point of time, you will have a time to go because the positive pressure, if you are giving, the patient already decompensated. See, already patient is decompensated, you are actually removing his efforts. So suddenly, if you are intubating and is removing efforts, the patient will collapse at that point of time. So this is the major important facts. So whenever in emergency, see that if you are finding the topics which are having the vicious cycle, so always try to break the cycle anywhere. That is the thing. And that's it from my point. Any questions? Yes.
You are witnessing a scenario of hypoxia and hypotension. Is it rational to use nitroglycerin, which is not only causes hypotension, of course, it does decrease the preload to the RA and RV, and at the same time it also causes tachycardia. And I don't know what is your observation of tachycardia with inhaled nitroglycerin when compared to that of a intravenous nitroglycerin, and is it going to act fast when compared to intravenous nitroglycerin? And are we not going to hasten this vicious cycle by further exacerbating the hypotension, which decreases the coronary perfusion pressure?
Actually, when we are giving the inhaled nitroglycerin, it is acting locally at the pulmonary vasculature. So at that point of time, it is not acting. When you are giving with an IV NTG, that is completely different. When you are going with the inhaled NTG, that is acting locally. So there is a temporary relief for the pulmonary vasculature, though pulmonary hypertension will be relieved at the temporarily. So that is the thing. And about the tachycardia, we have never seen the tachycardia with the patients who are on, when we are given with an NTG. Even the patients who are presented to ED with an history of some scape or some point of them, if you are using the NTG, then immediately there will be no tachycardia and all. Because if you are going, if the tachyphylaxis and the tachycardia will be takes place if you are going with the higher doses at that point of time. If you are going with the normal doses, we have not seen, and I think it is one of the side effects if you are going for the longer period of the time. That's it, sir.
One more thing, even Ashima madam is here. What is the role of ketamine? Is there any resurgence of literature for cardiostable induction and intubation?
Sir, the role of the ketamine, it is the sedative drugs, we have to choose based on the clinical scenario. So cardiac stable.
I am a professor of anesthesia. So ketamine, it's not to be safe in cardiac patients. Okay, it is going to increase the heart rate. It is going to increase the systemic vascular resistance. At the same time, if I am not wrong, it also has got its deleterious effects on the pulmonary vascular resistance. So there are certain other drugs what you can use. You need not use a single drug in larger doses or in its full doses to provide a desired pharmacological or clinical effect. Always you can use mix and match. Like you can use a combination of opioids, benzodiazepines, and if at all you want to use a cardiostable induction agent, yes, etomidate is there. Now it is clinically, it's available for clinical usage. And you can also use a rocuronium, which is one cardiostable muscle relaxant, non-depolarizing neuromuscular blockade, in a dose of more than, 1 or 1.2 milligram per kg body weight, which provides a rapid sequence induction and intubating conditions as that or equivalent to the succinylcholine. So probably that would be a better combination when compared to that ketamine, which you can use. Maybe in subanesthetic doses you can probably use, but that's not a ideal agent, especially when we are, I don't have a recent update on the literature evidence or something. Is there any literature?
Yes, sir, definitely it is there, sir. And as you were discussing about the etomidate and as well as the ketamine, like you were mentioning about the half the dose of the sedatives, which will have, because the sedatives are having the vasodilative properties and all, so it will causing still further hypertension. So half the dose of the sedatives can be used, and the ketamine, if you are using, even if not the half the dose, if you are using the regular dose also, it has an effect in, it plays an important role in case of the severe patients. There is a literature available, sir. There is a literature available.
Very stable. See, we as anesthesiologists, most of the time elective surgeries are done in ASA 1 and 2 patients. Their ketamine does all these plus points. But when the patient is hemodynamically unstable, it is all known that it will cause fall only. It will not increase. It will. No, it's not deterioration. That is what your contention was, that the patient will have increase in SVR and PVR. It will not cause at that time because already it will not work in that manner. So let us probably put up some during the lunch time and some more this on it in the group. We have a group. We can put it over there and. We'll move to the next talk. Thank you so much, and this is very nice that finally we could do some more article that in which Jipper said that they have not done. This is for me, so this is achievement. Thank you, Dr. Anusha. Thank you so much.
Thank you.
Yeah, thank you.
Thank you, ma'am. Thank you, sir. Now, moving on to the next topic is the radiology and blood gases. Thank you, sir. Now I request Dr. Ashima ma'am to present a memento to Dr. Mayangdir, sir. Dr. Rahul Rohan sir to present a memento to Dr. Anusha ma'am. request Dr. VC sir to present a memento to Dr. Shravan sir. I request Dr. V. Chandrasekhar sir and Ashima ma'am to present a memento to Dr. Shravan sir. I request Dr. Ashima ma'am and Dr. V. Chandrasekhar sir to give a memento to Rahul Rohan sir. Thank you, sir. Thank you, ma'am. Now, moving on to the next topic is radiology and blood gases. The first topic being is how to read the emergency CT chest. The chairperson of the topic is Dr. Ravinder Reddy, sir, head of the Department of General Medicine, Pratima Institute of Medical Sciences, Karimnagar. And the speaker of the topic is Dr. Professor Abhishek J. Arora, sir, Professor and Head of Radio Diagnosis, AIIMS, Hyderabad. I request the chairperson to please introduce the speaker.
Interesting lectures we had. Now we're going to move on to the imaging. It's been 200 years since we have a stethoscope invented. Recently, one article has come in Postgrad Medical Journal. Portable ultrasound chest is superior, is the new stethoscope for a pulmonologist. A nice article had come. So we are moving away from this to intervention, and thank God we have such a beautiful lecture today coming up from Professor, Head of the Department of Radiology from the prestigious AIIMS, BB Nagar. 16 years of experience and publications, 45 in index journals. And thank God for the COVID pandemic, we've been chasing CT chest more liberally now. I see many postgraduates of mine who want a CT for a patient on a ventilator. I'm more happy. Over to you, sir. I will be happy to listen to you.
I hope I am audible. Thank you very much. First of all, really thankful to the organizing chairman and the organizing committee to give this opportunity to me. It was a Sunday. I had to come from Hyderabad, so it was a little difficult to say yes, but madam said, no, it's going to be a very good conference. Already 170 delegates had registered. But the thing that changed my mind was, recently in my hospital, we had a white coat ceremony where the new first-year MBBS students take oath, charak shapat they take. And while giving those oath to those particular people or the candidates who have joined first MBBS, I just, to keep my ears on the ground, I thought that let me ask them what they want to become. Similarly, there was an internship orientation program because 31st December was when the 5th batch of AIIMS BB Nagar, that is AIIMS Hyderabad, they passed out. And I just asked them because we had to give them internship completion certificate and I had to sign on their logbooks. I have been given an additional charge of medical superintendent also. So while interacting with the students, I realized that most of them want to do emergency medicine as one of their PGs. So it was a really eye-opener for me. So I think we are at a juncture when slowly the radiology came up. Now it's the time of emergency radiology. So we do integrative teaching in our first year MBBS, second year MBBS. So it is a kind of a branch where there is so much of integration of various branches happening. And really a lot of good work is being done. I'm really happy that the lectures, the quality of the lectures were so good. The speakers were so nice. They're all Tom Cooks. They of the emergency radiology. They never had to see the slide to speak. Plus the clarity in the mind. And definitely, while giving orientation to those students who were entering into internship, I told them that, see, now you will get the real hang of the internship. You will interact with the patients. You will interact that what all subjects come into each department, and the fast mechanism of making a decision. See, for me, seeing a scan, definitely. In emergency radiology, we have to make a very fast decision. But there, the patient is in front of you and you have to make a diagnosis. So I got to learn so much from this conference that I don't know whether I will be able to teach you that much. So it is really nice to be here. Dr. Guna Silvan's message of being a leader and not a boss was very well taken. So thank you for that. So now I will just come to how to read emergent chest CT, because myself and Dr. Ashima had published few articles during the time of COVID when everything was on WhatsApp. Madam will just send me few images and I had to give the CORAD score to them. So all this has been done and dusted, but yes, radiology being an important diagnostic branch, you should know basics, how to read that particular chest radiograph of a patient who is in front of you. This one, right? No, it's not changing. So can you change with hand, or if you can? Yeah, so the theory part, you can read that thoracic trauma is one of the most common injuries that happen in polytrauma patients. And usually, even if the chest radiograph, the first modalities which we have to see, I think you give me a handheld mic. Because as I change the direction, the mic is not...
Maybe you can take this one.
Right, so thoracic trauma is one of the most common injury in polytrauma patients and the most common cause of trauma deaths. So I'll be first, without wasting much time, starting with the blunt chest trauma. So for the radiologist, the key principle which you all follow is that treat first, that kills first. And we should not intervene, we should not do the imaging that will intervene with your treatment or your postpone the treatment for the patients. So this means that any condition that threatens the airway, breathing, circulation, or I got to know airway, the biscuits and the coffee disability to be treated according to the priorities of the immediate patient survival. However, never before the stabilization of the patient. So now, what is the role of CT in chest trauma? There are different schools of thought. Few of the institutes say that it should be only the chest radiograph that should be taken, but chest radiograph do miss many of the findings. And also, many times the radiologist, I'm just telling you about my department, I have to encourage my residents to do reporting of the chest radiograph, and it takes a lot of energy from my side because they are not ready to sit there and do the chest radiography reporting. So immediately what happens, we give the radiograph, and the radiograph is taken up by the person who is treating the patient, and he or she may not be that much trained in reading those radiographs, right? So if I have to put so much of energy in teaching my students how to read a chest radiograph in emergency, unless I start a fellowship program in emergency radiology, which I am planning to do so. So in that case, it's difficult for you also to understand. But you as a person who is treating the patient should be aware of chest radiographs, of common findings which are there. However, to mitigate that, I think it's better that you send the patient directly for the CT scan. There have been a lot of articles of whole body CT scan in trauma patients. There have been articles that if you clinically find that the patient has thoracic spine trauma or there is a trauma to the chest based on the mechanism of the trauma, like if there is a fall by more than 3 floors or 3 feet height and all those parameters, then you can directly send the patient to the CT scan chest. So the stabilized patients need to be taken, and this slide just tells you that how the chest CT is overall adding value to the chest radiograph. So definitely it picks up more and you help to reach the diagnosis faster, and also whatever diagnosis you have reached on radiograph, definitely that will be getting confirmed. So WCT, that is whole body CT, as the first step in polytrauma patients, yes, very well taken. And now with more and more usage of CT, and let me remind you, there may be some few people who may be adding that there's a lot of radiation, but nowadays with low dose CT algorithms that have come in the new CT scanners, the dose is not much that we are giving to the patient. Also, the cost, the benefit is to cost ratio, or the benefit is to radiation ratio is also much in favor of doing the CT scan. So what all we see in a case of patient who in the lungs, in a case of trauma. So first is the pulmonary contusion, the prevalence you can read, but how does the pulmonary contusion happens? It happens because of the direct trauma. It may happen because of there is an emergent, there is a shear force, or there is a deceleration trauma happening. And what you can see is that there is pulmonary contusion. It will present as a focal or multifocal areas of confluent ground glass deformity. So there will be ground glass deformity. The parenchymal changes won't be disrupted. So the anatomy won't be disrupted in contusion. It is just that there is more leakage of edema and blood within the alveoli. So it's just like what Mayank showed you in the red box, the alveoli, small blue blobs, they will get filled up with blood, or maybe with the edema or water. So because of that, there will be ground glass opacities. The contusions may be radiographically seen after 6 hours of the injury. So you have to keep in mind that imaging predates the imaging succeeds the clinical findings which you will find out much earlier in the patient. So it is just for the confirmatory part. Also, you should make sure that the contusions, if you have diagnosed in the first CT scan, it should resolve by 24 to 72 hours. So if something persists, then it was not contusion, it was hematoma, it could have been laceration, which you misdiagnosed as a contusion. So contusion will happen 6 hours, or will come to 4-6 hours after the injury has happened. So by the time the patient reaches the hospital and you have made him hemodynamically stable, the CT scan happened, the contusions may start appearing, and they will definitely wither away by 24 hours to 72 hours. So this is just a diagram to show, or this is just the radiograph of the patient, and you can see that there is contusion here. The pointer is not visible, but it's okay. So you can see that there is a lot of ground glass opacities happening. Now, in CT scan, everything is black and white. Many times as a radiologist, we also have to ask the history. We have to clinically correlate the history of the patient and then reach a diagnosis. Then in this particular case, when there was no previous imaging, or there was a previous imaging of a normal CT scan, then definitely in this particular case, the ground glass opacity which I am seeing is because of the contusion and the trauma. So you can see there are multiple ground glass opacities seen in the basal segment of the lungs, in both the CT, the coronal reformatted images, as well as the axial images, and this was nothing but a case of contusion. Another case of the contusion, but yes, in a emergency setup, the pneumothorax, which was not very clearly seen on the radiograph, it got picked up on the CT scan, and definitely it does make a difference in a case of emergency situation, because this small pneumothorax may get aggravated once you are putting more of ventilation to this particular patient. So these were all the images of contusions. Now coming to the next severe step. The next severe step is the laceration. Now laceration is nothing but the evident tears in the parenchyma. It again happens because of the shearing stress force, or maybe because of the direct puncture. And then because of the recoil of the lungs. Now in laceration, what is happening? The lung tissue or the parenchyma is getting cut. But because there is a surrounding normal lung, and the lungs that are injured, they recoil and they form a round shape. Okay, so it may appear as a round shape structure in a case of trauma, and usually they get blood filled. So from wherever the lungs get retracts and takes a round shape, the area peripheral to it will be filled up by either water or blood. So then you may find there is an associated hematoma or air fluid levels. So that is nothing but the lacerations. Now lacerations, they are more visible. Again, coming to this thing, they again become more visible days after the trauma with shrinking of the edema and the hemorrhage. And also, many times in India, we see this kind of cavities. So we always put that these could be tuberculous cavities, but no. If we ask the history to the patient that did you have any trauma previously, and the patient says yes, and if the cavity is very thin-walled and regular, then definitely it suggests that it was a post-traumatic pneumatocele. So these are thin-walled, regular pneumatoceles that form after laceration. So be mindful if the patient had previous trauma, you get to see a patient, he's coming to you in your clinic with again shortness of breath, then it could be because of not TB, but because of the post-traumatic pneumatocele. So there are multiple types of lacerations that more pertains to the radiologist. It could be centrally located, type 1, it could be peripherally located, where it could be tubular in shape, it could be again peripherally located, where it is not a tubular shape, but it is round shaped. And then in case of pre-existing pleuropulmonary problems, there could be a more laceration. So this is a classical example on the CT image of a laceration which is almost 3 to 4 days old. So you are finding a tubular structure surrounding it. Again, there is a lesion or there is a opacity which is seen. Another structure where, and usually lacerations in the base of the, or near the spine, in the paraspinal location, they happen because of the shearing forces. When the lungs get cut, this could give rise to a large pneumatoceles later on. So this is nothing but, again, lacerations are more dense than that of contusions. And if you repeat CT after 48 hours or 72 hours, if the opacity is not going away, then definitely that was not a contusion, that was a laceration or more. That means it was more of a hematoma. So another example of contusion and laceration both on the CT scan as well as on the radiograph. Now, there could be multiple complications that can happen. So in this particular case, there was a lung herniation, there was a large blunt trauma, and you could find that there was a herniation of the lung anteriorly through the chest wall. These are severe cases which can be easily picked on CT scan, but may not be on radiograph. So one step ahead of laceration, atelectasis. Atelectasis, again, POCUS, very helpful in institutes of tertiary importance. But nowadays, the government is very keen to put that tertiary setup even at the PHC levels. So POCUS becomes is the investigation of choice. You put an ultrasound probe, you can see an atelectasis. You can also differentiate between obstructive atelectasis and a non-obstructive atelectasis. How? Because if you are seeing an air bronchogram by putting a POCUS, definitely if the air inside is moving, definitely it's a non-obstructive atelectasis. That means the air is going in and going out of that particular consolidated lung. And if there is obstructed, then the air between the air bronchogram or the sonobronchograms, what we say, will not move. Very beautifully, the shred sign was shown by the first speaker, Rohan, and very nicely he could find out that how the POCUS is. Now, ultrasound in emergency medicine, I feel, is the second stethoscope. So in my institute, we are procuring almost 12 ultrasounds for many departments who just want to do POCUS and help the patient. See, eventually, what is the aim? Final aim is to help the patient and reach a final diagnosis and treat him. So atelectasis is nothing but where you will see crowding, there will be collapse. And this is nothing but a classical picture of atelectasis of the lungs in the basal segment where you are finding the collapse and the crowding of the vessels. So I know I'm standing between you and the lunch, but yes, I'll just show you all the major pictures what I have brought for you. So pneumothorax, again, very easily picked up on ultrasound as well as on radiograph. In a trained eyes, yes, but most of the radiographs of emergency patients are taken at bedside with lot of lines and lot of catheters with ECG lines and everything, which may mistake them as, again, the importance of CT scan to be done in such cases if the patient is hemodynamically stable. So pneumothorax as one of the examples. Sometimes if the pneumothorax is small, you can prone the patient and again try to evaluate, because those are the basal areas where the air gets collected and can be easily seen. But still, in a trained eyes, I would say the pneumothorax can be very easily picked up on CT scan. So tension pneumothorax, again a medical emergency, definitely has to be told to the person, treating person, as well as a radiologist, we are training ourselves and training our residents that immediately the needle should be put in. And how to put, where to put, that we are taking them in the training during the course for the tension pneumothorax. So hemothorax is something when there is a leakage from the arteries and there is an accumulation of blood in the pleural space. So we started with contusion, laceration, higher grade, atelectasis or consolidation, higher to that, and then there is a hemothorax. Now the fluid has started trickling into the pleural space. So between the visceral and the pleura, there will be collection. So CT and diagnosis again made by that. CT diagnosis, you all know, if the bleeding is acute, then definitely the HU values will be around 45 to 60 HU. So if this would have been a fluid, simple fluid, but yes, if the HU value in such cases, please tell the radiologist to do a contrast enhanced study, because in this particular case, you can clearly see that in the second image, or in the cornermost image, there is a leakage. There is so much of extravasation of the contrast happening in the paravertebral location on the left side. And also in this particular case, there was a hilar artery that was leaking. So you can easily find out where the leak is, and eventually the whatever intervention radiologist or any person who is doing the surgery has to be called in. Okay, another case of delayed hemothorax in a case of leaking intercostal artery. So many times hemothorax could be a delayed presentation, so be mindful of that. Placement, you are more trained how to place the tube, but definitely for pneumothorax, you have to go from the mid-axillary into the anterior and superior aspect of the chest, while for the hemothorax evacuation, you will have to go more towards the posterior and inferior aspect of the chest. So revision, this particular one section has all the things. So on the left side, you are finding there is a contusion. On the right side, bone and chest tissue trauma. There are multiple softwares, and artificial intelligence has come into radiology in a big way. So we can straighten the ribs and find out where all the fractures are. So these are very beautiful. Soft bonard can happen. So again, decrease in the size of the right ventricle. And then there is a septum which is more towards the left ventricular. So all these things you can see. Different topic. Why? Because there is something known as minimal aortic injury. In minimal aortic injury, what we are learning is that those injuries can be easily resolved or can be solved by just keeping the patient just under observation. So no intervention needs to be done. So trauma becomes that we have, but in the minimal aortic injury defect seen in the aorta, less than 1 centimeter, small bleb, yes, it could be either a thrombus or could be just an intimal tear. Another case of coronal on that particular patient, we are seeing 2 intimal tears inside. But again, such injuries should not be touched. The patient should be just kept under observation, immobile. Definitely immobilization has to be done. Small dissection of the aorta, again the injury there. This is grade 4. It is no more a minimal aortic injury. Here the extravasation of the contrast can be seen. Traumatic diaphragmatic injuries, again, you can easily check with the diaphragm. There will be herniation. There will be herniation of the gastric contents into the diaphragm. Can be easily made by even radiologist as well as the treating physician if we are finding that there is a diaphragmatic injury. So non-traumatic, non-vascular chest injuries, again, it is infection. Again, as I told you, everything appears black and white. We have only, so how many shades of gray can our eyes check or see? I usually ask because as a radiologist, it becomes very easy, it becomes very important for us. So our eyes usually can see between only 16 to 20 shades of gray very nicely. Okay, so 15 to 20 shades, and then we have the CT is giving me 2000 shades of gray. Why 2000 shades? Because minus 1000 HU to 0, that is fluid, then plus 1000. So it's nothing to do with the 50 shades of gray, which many audience people are laughing. But definitely what our eyes can perceive is just 16 to 20 shades of the gray. Okay, so what I'm trying to tell you is that for a radiologist also the job is not simple. Everything appears black and white. And in that black and white, we have to find out the pathology, tell it to the clinician or tell it to the person who is treating the patient, and make a correct diagnosis. So definitely windowing helps. And in windowing, definitely if the clinical history is not that of a trauma, then the same ground glass opacity becomes infection, and the same area where I would have said as hematoma becomes consolidation. Okay, so that's how the diagnosis, it evolves, in keeping into mind the clinical history. Then hypersensitivity pneumonitis, classical picture where you find all the centrilobular ground glass opacities in the lungs. So this is nothing. Again, acute exacerbation can happen. The respiratory distress syndrome, definitely it's more of a clinical diagnosis. It's not a radiological diagnosis. But yes, clinically, if the patient is having hypoxemia and all the parameters of the ARDS is are getting fulfilled, then definitely after asking the history, the same consolidation becomes ARDS. We usually try to compare with the previous reports or the previous images of the patient, but in patients in India, they usually want to test it's a viva for us every day. They do not give us the previous reports, they do not give previous films, but that is all is changing. Just now in being in like MS, I'm we are starting that Government of India program. Just like UPI has come, that from any bank, from any mobile, you can just put in you can change the money from one bank account to another. There is something coming up is UHI, that is Unified Health Interface. So if the NIMS or if all the institutes, they get, Telangana has a lot of institutes that have come over it. ABDM platform, that is Akhil Bharatiya Digital Mission platform. So if you come over that, then definitely I am attaching all my reports on that. So every day AIMS is having some 1,000 reports of radiology that are coming to the ABDM platform. Then if the patient gives you the OTP, if the patient comes to you, then definitely you can just immediately put in you have to ask the permission. The patient has to give you the permission, and OTP will come to the patient's mobile, and you can put that OTP in your ABDM platform of your institute, and you can see all the old reports and all the old scans of the patient. So it's going to be a game changer in next 5 to 10 years, most likely. All of us work together. So ARDS, again, this is how it looks on radiology. Diffuse alveolar hemorrhage, again, a case of a non-traumatic injuries. Again, you as a emergency physician know better that how to go about it, what you have to check, whether ANA in scleroderma or P-ANCA or C-ANCA. So there are multiple problems, multiple syndromes or multiple diseases that can give rise to diffuse alveolar hemorrhage, but this is how it looks. There will be interstitial thickening and ground glass opacities both. It appears very similar to the alveolar proteinosis, what we used to call it on HRCT. So fat embolism syndrome, yes, again, one of the emergencies where the patient has been treated by a fracture, usually a femur fracture, and then there is a fat globules that get circulation in the blood. I happened to see one very beautiful case where we could see the fat globules in the IVC. So I did not put the image, but yes, then it becomes a fat embolism syndrome. Again, you have to be aware of, and again, as a radiologist, we have to be aware of that what the patient is suffering from, and then immediately give the diagnosis. Acute pulmonary edema, you all are aware of, bat wing appearance, and there is a overload of the fluid and the fluid coming into the alveoli. Acute aspiration, I'll not go into detail. Pulmonary embolism. Acute and chronic, you should be aware of. So this was a case of a saddle aneurysm where the thrombus, sorry, not aneurysm, the thrombus, where the thrombus, saddle thrombus, where the saddle thrombus is extending into both the main pulmonary arteries. And again, the findings. Chronic, how do we differentiate? Again, the history, and if there is a classical findings of calcification within the thrombus, then definitely it becomes a chronic pulmonary thromboembolism. So thank you very much for this. Definitely, as a CT being a very useful modality, my purpose, it was a very big topic actually, to teach CT scan in half an hour for emergency chest cases. But yes, I try to incorporate and try to tell you that what are the things that are important. So thank you very much.
I think it's a beautiful lecture. Tough time to condense it to a small thing. And we saw the paradigm shift from a clinical perspective to ultrasound chest, to radiology, imaging of CT. Traumatic, of course, there's no doubt that the cornerstone is going to be CT. We have two questions for you. With the advent of a lot of ultrasounds and high-frequency transducers, we're using it for ABG also in our hospital today. Is there any condition where you prefer ultrasound or a CT in any traumatic or a non-traumatic condition? And the second question is, we have low-dose radiation now, ultra-low-dose radiation CT has come. Will it replace our conventional chest X-ray?
Okay. So see, how the market forces work is that, regarding the first question, so any pathology that is peripheral, touching the pleura, and giving you a good window for ultrasound waves to pass through and give you an image, definitely you can, ultrasound becomes the first choice. But yes, just like what gynecology people are doing, we scan it, we give them the report, they scan it again. So most of the gynec scans, the early normal gynec scans are now being done by the obstetricians themselves. Why? Because again, the waiting time, the market force is such that radiologists are not available very easily. There is a lot of other specialized works have come for the radiologists. Now the radiology itself is branching into so many other super specialties. So because of that, and plus with advent of artificial intelligence, so anything that is peripheral can give you a good sound window, can be done at the bedside, whether you call a radiologist to the bedside or whether you yourself could just put a probe, you can detect it. So definitely there, the CT can be replaced. But again, I just missed it. So as the obstetricians are learning it, similarly, it will be a learning curve for most of the emergency physicians also. So let the CT happen. The pathology is peripheral. Go to your department, put one probe and see whether, if I have written that it's a atelectasis with CT bronchograms. So you will find the corresponding picture as a sonobronchogram. See, the main role, as we advance in our career and as we change our positions, the vision and the purpose becomes little different. So as an MS, my role becomes that the patients who come to the institute or to the hospital should be treated well. The diagnosis should be made well and they should go home in a healthy state. So yes, with integration of all these branches, the knowledge, it can be done. The ultrasound may replace. Coming to CT replacing radiography, no, it won't be possible because radiograph it's very easable. Portable radiographs are much easily available. I'm doing one radiograph in 30 rupees. The CT scan I'm charging 750 rupees. So definitely it may not replace. The patients, still in India, the patients are not that much rich to directly go for a CT scan for any case. But yes, in a case like injuries or trauma, CT becomes the investigation of choice. Yeah. Thank you.
Thank you, sir. Now I request Dr. Ravinder Reddy, sir, to present a memento to Professor Abhishek J. Arora, sir. Sir, now I request Dr. V. Chandrasekhar Reddy, sir, to give a memento to Ravinder Reddy, sir. Now we'll disperse for lunch for half an hour. The lunch is served in the next room. Thank you.
Good afternoon, everyone. I know it's a post-lunch session. I know everyone has just had a good lunch. And I hope you're all not sleepy. So just to be sure, can everyone please get up once? Just get up and sit down again, please. Okay. So the boring topic of the day, the biochemistry part. I know not everyone will be comfortable with this, but you have to go ahead with it. So I promise to be quick, and I just want an interactive session. So this is a case that one of my colleagues had a few weeks ago. Let's say, okay, someone had Pushparaj in the morning, so let's say Srivalli. 82-year-old female, came with, who's a known hypertensive, diabetic, and suffers from insomnia problems, taking zolpidem, telmisartan, and metformin. She's been bedridden for the past 1 year. Now the relatives brought her with complaints of excessive sleepiness from the past 2 days. We have examined her. My colleague was very thorough with his examination. He found that the airway was potentially threatened. But she was tachypnic with a respiratory rate of 27, saturation of 83. Not a very unusual finding with zolpidem, but yes, this was there. A pulse rate was 96, BP was 100/70, and GCS was E3V4 M6, and GRBS was 156 milligrams per deciliter. From this, you would not look for a typical respiratory patient, but can anyone think what could be the cause for all this? Can anyone just shout out? I'm not able to hear anyone. Sorry, sir. This patient was actually had overdosed on zolpidem, so she was excessively sleepy. That is what the relatives had told. But when we had done the ABG, this is what we found. So what are we looking for? So when we look at an ABG, we actually look at a few findings. First, we look at the pH, PCO2 and oxygen levels. Along with this, we look at the bicarbonate. Once we are done with that, we start looking for the HB and oxygen saturation to confirm whether it's an ABG or a VBG. So after this, we had gone ahead and looked at the electrolytes. Then we looked at the glucose and lactate. So only leaving aside the lactate and the slightly lower oxygen and carbon dioxide, we couldn't find much abnormalities. So then my colleague went ahead. He then looked for further evaluation, and from this we couldn't just find anything. So, but since the airway was potentially threatened, my colleague went ahead. He put an oxygen by face mask, put 5 liters oxygen, and then went forward to evaluate this patient. So during this course, while my colleague was evaluating, let's go ahead and do some study into the physiology. What could be the problem here? So at this stage, we know, I think this is everything that you have read in MBBS. So I'm just brushing it up for you. If you're not that interested, but still you'll have to listen to this. So what is the thing is atmospheric pressure, the patient starts breathing in, while the patient is self-breathing, it will be a negative pressure. So at a negative pressure of -6 centimeters of water, the patient starts breathing in. Then at that stage, the transpulmonary pressure will be around 4 millimeters of mercury. Intrapleural pressure will be -4 millimeters of mercury. Then intraalveolar is supposed to be 0. So at this stage, then from this we'll go ahead with what will be the oxygen saturations. So the oxygen saturations here, at the exhaled air will be going out and the inhaled air will be going in. So oxygen in the inhaled air will be around 104. It will be 5 times what is the saturation of oxygen that is being inhaled. So normally it will be around 5 times of 21, that is 105 or 104, and PCO2 will be around 40. And in the mixed venous blood, oxygen will be only around 40, while carbon dioxide will be around 46. And in the oxygenated blood that is taken into the pulmonary vein that we have, it is PO2 is 100 and PCO2 will be 40. This is the normal levels. From this we have to calculate what will be the oxygen levels of the alveolar oxygen, that is P alveolar oxygen. This is the alveolar gas equation, that is PO2 is FiO2 into atmospheric pressure minus water pressure multiplied by that, and minus PaCO2, that is arterial oxygen, carbon dioxide level by respiratory quotient. When we substitute the levels, it will come to approximately 0.21 multiplied by 760 minus 47 minus PaCO2, which is expected to be around 40 by 0.8. So approximate value at this level, can anyone calculate? It will be around 100. Okay. So that is the expected level of oxygen in the arterial system. So the level of oxygen from there, if we take it in a range, 100 plus or minus 20. Our patient was having around 79.9, which is just a little below the 80 mark. Then the oxygen hemoglobin dissociation curve. What are the causes for it to be shifted to left and what are the causes to be shifted to right? Decreased temperature, decreased PCO2, increased 2,3-DPG, and increased pH. This causes the shift to left, and to the right is the increased temperature, increased PCO2, 2,3-DPG, and decreased pH. So these are the causes. So from here, this part is your physiology. Now let's come to the pathology of it. What are the 4 types of respiratory failure that could happen here? And what could be the potential thing that could be seen in the patient? So can anyone tell me what is type 1 respiratory failure? What could be the main pathology here? It is hypoxemia. It is not hypoxia, it is hypoxemia. So, and what is the type 2? Hypercarbia. Type 3? It is mixed, but more predominantly in type 1, but it is seen in perioperative cases. And type 4? Shock, decreased tissue perfusion. So I've written it wrong myself, so I apologize for that. It's not hypoxic, it is hypoxemia. So what are the causes for type 1 failure? Causes are, as you all commonly know, infections, COPD. We have been hearing all morning, so it is infection, COPD, asthma, pulmonary edema, pneumothorax, chest wall deformities, CNS depression, and ARDS. So type 1 failure is a very common failure, that is decreased oxygen levels due to multiple causes. The predominant difference here is that it requires reduced oxygen to be absorbed and not decreased carbon dioxide exchange. So what can be there? In this particular patient, CNS depression was already there. There could be an infection and there could be pulmonary edema. So what could be the first treatment that we'll do? We've already started the patient on oxygen. We go ahead and we might put her on high flow nasal cannula or start her on BiPAP. My colleague, he started her on BiPAP, but after that, a change happened that forced him to change his course of treatment. Type 2 respiratory failure, again you all saw the same causes, infection, COPD, asthma, respiratory fatigue, chest wall deformities, CNS depression, ARDS, pulmonary embolism, pulmonary alveolar hemorrhage. Here, the first line treatment is not oxygenation. It's already there's hypercapnia. So unless it's in the permissive limits, you have to go ahead and put the patient on either BiPAP or intubate the patient and treat the cause. So now what happened was, while my colleague had started the patient on BiPAP, the patient suddenly had one episode of vomiting. So that became an emergency, and so my colleague immediately intubated the patient. But it was not my colleague who had done the intubation while he was supervising. It was a first-year resident who had put the intubation. After intubation, there was some issues during intubation, and following that, this was the ABG. So can anyone tell me what is wrong here? It is, first thing, let's go with the ABG diagnosis. Then let's see for the cause. It is respiratory acidosis. Then, whether it is acute or chronic. So these are the two things that we have to see. So here it is acute. Since we already know the previous PCO2 levels, we know that this is acute. And it had occurred during intubation. So most likely the tube was not properly placed or tube was blocked. So one of these two could have happened. So what is acute respiratory acidosis? We know that in respiratory acidosis, while pH decreases, PCO2 increases. Here, what is acute? pH decreases by 0.08 for 10 millimeters rise in PCO2. Alternately, bicarb increases by 1 for every 10 increase in PCO2. In chronic, it will be around 0.03 decrease in pH for 10 in PCO2 and 3 to 4 milliequivalents of bicarb for every 10 increase in PCO2. So the causes, again, CNS depression, sedatives, CNS disease, obesity, hypoventilation syndrome, pleural disease, large pneumothorax, effusions, COPD, again ARDS, musculoskeletal and neuromuscular disorders, that includes myasthenia gravis, Guillain-Barré syndrome, kyphoscoliosis, etc. So, what is the alternate? Now we have already seen the acidosis. What could be the situation of alkalosis? Alkalosis is, how do we know whether it is acute? It is 0.08 increase in pH for decrease in PCO2, and bicarb will be 2 decrease for 10 increase in PCO2. It goes in, it is not 1 like it was in the previous one, it will be 2. And in chronic, it is again 0.03 increase in pH for 10 decrease, whereas for bicarb, it will be 5 decrease for 10 increase in PCO2, 10 decrease in PCO2. So, what could be the causes? Again, CNS disorders, drugs, pregnancy, decreased lung compliance, respiratory alkalosis, which could be due to in the absence of hypoxemia. What could be the things again causing the respiratory alkalosis in the absence of hypoxemia? Anxiety, sepsis, one of the most common causes that we see. Now my colleague, he was scared, he went ahead, he repositioned the tube, then after repositioning the tube, we still find the pH to be decreasing. And PCO2 has decreased, which says that at least the patient is able to wash out the PCO2. So since we know that the patient is washing out the carbon dioxide, we know that the tube is in position. He had checked the tube, but still the patient is not oxygenating. How do we know the patient is not oxygenating? The oxygen saturation is still 6.7. In spite of placing the tube correctly, the patient is in this condition. So what could be the causes here? Tube has been checked, tube block has been is not there. So we have taken that part out. Tube is not there. So what else could be there? Sorry? A bit louder, please. I told you the patient had vomited. The patient has aspirated. Massive aspiration. After correcting this pH, after the patient was stabilized, when we had done the CT, we found that there was almost 1 liter that was aspirated. Following that, we found the lungs to be completely filled with fluid. The patient had aspirated so much that there was the lung was completely blocked. So what could be the other causes that could cause the same picture? Pulmonary embolism. One of the causes that I think Gunashilan sir had said in the morning. We could have it without anything. A sudden massive pulmonary embolism could cause this. ET tube obstruction and machine failure we have already discussed. Aspiration we have seen in this patient. Coronary thrombosis is one more cause that could, coronary thrombosis leading to pulmonary edema could be one of the causes here. So these are some of the most common abnormalities. Now I'll come to one of the most common scenarios that we see in emergency. But if you look in Tentinelli, it will be error 404, you will not find it as a single chapter. A 27-year-old male, alright, let's go back to Pushparaj here. 27-year-old male, he has no prior comorbidities. This patient I had seen just 3 days ago. So it was my patient. Fever, cough for the past 5 days, shortness of breath from just 12 hours. But he was very tachypnic, respiratory rate was 40. Saturation was 65 in spite of breathing at 40, respiratory rate of 40. Pulse rate was 147. He was very anxious. I'm sorry, it's not 600, 90 by 60 BP. And GCS was E4, V5, M6. But he was just not sitting in one position. Orthopnic, tachypnic, very bad patient. And bilateral coarse crepitations completely. And we just couldn't control this patient. So can anyone give me the differential diagnosis here? Sudden onset without any prior comorbidities, a patient of this kind. Sorry? Louder, louder. This is one of the most common diagnoses. Viral pneumonias leading to what? ARDS. So, this was the ABG that we had. pH was 7.28, PCO2 was 53, and this was the lung picture. BICOB was 18, 4.6 lactate. And the lung picture, we had intubated this patient immediately. So this was the X-ray taken after intubation. So what are the criteria for ARDS? Old criteria, Berlin's criteria were there. That's been there for more than a decade. So I'm sure everyone will remember. It should not be a cardiac cause. It should be purely respiratory within 1 week. And it should be diagnosed both on X-ray and biochemistry. So 4 things: time, that is less than 1 week, respiratory cause, non-cardiac, and should be proven radiologically and biochemically. So what are the biochemical causes? PaO2 by FiO2 less than 300, and in mild it will be 200 to 300, 201 to 300. In moderate it will be 100, 101 to 200, and in severe it will be less than 100. The PaO2 by FiO2 ratio. But there is a changed definition of ARDS in 2023. This shows that the additional criteria is if there is a resource constricted settings. That is, if you do not have ABG, and SpO2 by FiO2 less than 3.315 with SpO2 less than 97% without any support is also indicative of ARDS. And again, if it is 315, it will be 210 for mild and 105 for moderate. So this is the new definition. And if there is any high flow nasal oxygen support, then more than 30 liters per minute, or NIV or CPAP of at least 5, a PEEP of at least 5. That will also be a criteria for ARDS. So what are the causes? The most common cause that we see: viral pneumonia, sepsis, chest traumas. Then the patient could be in shock, acute pancreatitis, DKA. All these could be causes. But it is, as I said, it's a syndrome. It was previously, it will not be seen in a single chapter. You have to read it up from all these places. But as a single thing, it has to be treated in an emergency. How do we diagnose it? Again, the X-ray, the CT findings, as Sir had said in the pre-lunch session, there could be homogeneous opacities, or if it could be in the dependent positions, there could be single consolidation with multiple homogeneous opacities. So how do we treat this? In mild ARDS, we can go with BiPAP. But if the patient is going towards moderate or severe, we have to intubate and we have to treat the cause. So what are the intubation strategies? So I think Mayank sir had just briefed you in the morning. So I just go back again and go ahead with this. So when we initialize, what is our goal? IE ratio, we should do it with a target of, with a tidal volume taken per kg body weight, 6 ml per kg body weight, with a P-plat of coming to around 30. Then we wait for 30 seconds, adjust the PEEP and FiO2 according to the ARDSNet table. That I'll show again. Sir had shown in the morning, but I'll show again. Then if we have a pH, then we correct according to the pH. If we don't have the pH, then we have to go with the PEEP. Adjustment of PEEP and VT till we get adequate plateau pressure of 30. Once we get the adequate plateau pressure of 30, then we go with the ARDSNet protocol. Here, FiO2 to PEEP. We start with 0.3 FiO2, that is 30% FiO2, with a PEEP of 5. That is low PEEP strategy, low PEEP, higher FiO2 strategy. From here we go from 0.3 to 5. From there we increase the PEEP to 0.4. This is the way we have to follow this table. And with the 0.4, then we go with 5, maintaining PEEP of 5. Then increase the PEEP to 8, maintaining 40% saturation. Then again go ahead, increase the FiO2. The same thing, then we have to probe. If wherever we see a constant FiO2, then we have to increase the PEEP. Wherever we see a constant PEEP, we have to increase the FiO2 till we reach 100. Alternately, we can go with a higher PEEP strategy where 0.3 is maintained till the PEEP is increased to 14, and there 14 is maintained to increase to 0.4, while we keep increasing it alternately the same way. So what is the difference between this high PEEP and low PEEP strategies? How does it change the patient mortality? Can anyone say what will be the difference? This is one trial that came 20 years ago. Higher PEEP versus lower PEEP in patients with acute respiratory distress syndrome. This was done by the Arts Clinical Trials Network. They found that there's no difference. You can go with either strategies and they found no difference. So the recruitment strategy, sir had talked about proning. Or other than proning, we can use multiple recruitment strategies like 40 centimeters of pressure for 30 seconds and then decrease it back to 30. Otherwise, increase PEEP for 40 seconds, PEEP to 40 for 40 seconds and increase and again titrate it back to get a plateau pressure of 30. This helps in recruitment. Mostly it happens within the first 10 seconds. If it doesn't happen, you have to go with an alternate strategy. Otherwise, you can go with slow increase of inspiratory pressure, stepped up increase. This is another strategy that was recently published. You go up with a stepped up recruitment strategy. These are things that if I start explaining, it'll take me, I already got a bell, so I guess it'll take another half an hour. So I'll leave that. But again, is proning beneficial or not? Proning, yes, it is beneficial. But what are the other strategies that we have in the emergency nowadays? Can anyone tell me what is the newest equipment, the latest craze in ARDS or in CPR in emergency nowadays? ECMO. So, what about ECMO? So ECMO, again, the CSER trial found that ECMO is beneficial in patients of ARDS if you cannot go ahead with any ventilatory strategy and patient is affordable. But which of these two is beneficial? Both are beneficial on their own, but prone ECMO trial, if we look at it, compares both proning and ECMO in same patients. Out of 170 patients, they found that both categories had 44% recovery, whether proning was done or not. So proning did not decrease the time if there is ECMO available. So if there's ECMO available, then go ahead with ECMO, proning doesn't help. But if there is no ECMO available, go ahead with proning. Thank you.
Good presentation. Yeah. Okay.
Thank you so much, sir, for such a great talk.
Yes, sir. Proning is not equally beneficial, but if ECMO is there, then go ahead with ECMO. If there is no ECMO, then patients in, I am currently working in Yashoda, sir. So in my setup, yes, ECMO is the more beneficial entity. But considering the audience at large, I'm sure ECMO will not be available at most places. So previously, I was at AIMS, there was no ECMO. So we had to go ahead with, sir, with, compared to each other, ECMO is always better, sir. Proning has a benefit up to 44%. ECMO by itself will have around 56%. But when we compare both, it will again come down to 44% if we do proning. Because the complication of proning, there's hypotension, there will be patient discomfort, disconnections and other things. So in this proning, if it can be avoided, it is better to avoid proning.
I just want to add something to this thing. The proning is something where we start after initiating initial strategies where we, pertaining to the management, pertaining to the low tidal volume or whatever, initial interventional strategies can be started, and subsequently maybe the patient can be taken to proning. But ECMO as such should be initiated from the beginning.
Yes, ma'am.
Right from the time.
Yes, ma'am. Actually, in even the ProSeva trial, which I had put in the first thing, that actually says it has to be initiated. Proning is most beneficial if done within the first 16 hours. But most people do not do proning within the first 16 hours. They do it only after 24 hours. After trying all the recruitment strategies, then they go ahead with proning.
Yeah.
But ECMO, wherever it is available, CSER trial, they did it within the first 5 hours. So that the difference comes from there itself.
Correct, correct. I totally agree with you. So what I meant by saying that one is that when a patient presents to the emergency department, for example, so when we consider the diagnosis and all, our initial management after the primary survey and secondary survey may not be a proning.
Yes, ma'am.
So initial interventions
in
do.
emergency, there's very few people do proning at all.
Yeah,
if they do at all.
But as such, ECMO, if at all, and of course, cost-benefit ratio does matter and cost do matter. But the thing is that if in a best center, if at all the patient is found to have a refractory cardiac arrest, already resuscitated patient, immediately emergency ECMO is the initiative.
Yeah, yes,
yes, by
if available.
Thank you, ma'am.
Good presentation.
Next topic, emergencies in the background of pulmonary tuberculosis. And I'm very glad and honored to invite Dr. Nayan sir as speaker. Consultant of Emergency Medicine Department in AIG Hospital, Hyderabad. And let me invite Dr. Vishwa ma'am to grace the stage as chairperson.
Care, and apart from his clinical expertise, he has many continuous ongoing research projects, and he has multiple case reports and original articles published in indexed PubMed journals, and he has achieved accolades by being a speaker at national and state emergency medicine conferences, and he has been a passionate advocate for free open access medical education and founder Emergistan, which aims to provide rapid emergency care to rural populations by turning existing pharmacy stores into tele-triage diagnostic facilities. Over to you, Dr. Nayan.
Thank you, ma'am. Thank you very much. Good afternoon, everybody, and thank you for giving me this opportunity. And thank you for staying back after lunch. So, and I am sure, I promise I will not bore you. And so this topic we all know, this is tuberculosis. Like there is a advertise in Telugu which says, Ammani marchipolemu, Ambikani marchipolemu. So tuberculosis ni kuda marchipolemu, respiratory emergencies lo. So let's begin with the importance of this for an emergency medicine background. Is that In the ER, people come, people go. There are a lot of people coughing in our faces every day. So we don't know who is what. In this situation, to have a low threshold to identify the people coming with emergencies, cough, and a lot of sputum coming on our mouth, we need to have low threshold for TB. And this TB is a major killer, and 1/3 of the world's population at some point has been infected by TB, and 1.4 million die from this disease yearly. So that's why emergency medicine and emergency physicians must know the various spectrums of presentation of this disease. So the predisposed group of individuals are usually immunocompromised, such as HIV patients, those with occupational history, diabetes, CKD patients on hemodialysis who are usually prone to more of hospital-acquired pneumonias, malnourished patients, those with immunosuppression in solid organ transplant, post-ileostomy, post-gastrectomies, the drug abusers, those who are having COPD, smokers, and those who are living in prisons and also in old age homes. The pathophysiology, I would like to brush it up quickly. We all know about TB, we have studied in MBBS, but this is caused by Mycobacterium tuberculosis, and this is, humans are the only reservoir for MTB. There are other two forms, Mycobacterium bovis and africanum. These are usually in immunocompromised patients. This is an intracellular, aerobic, non-motile, non-spore forming bacilli with a waxy lipid coat. This lipid coat is causing it resistant to decolorization with acid alcohol, and therefore this is also called as acid-fast bacillus. This MTB is very slow to grow, and it takes 4 to 6 weeks on a culture, solid standard medium, and it produces neither endotoxin nor an exotoxin. So the cell components are usually immune suppressive, few are immunoreactive. They form granuloma, and they are activating the macrophages, and we will see the stages of this. So this is an image of a LJ medium with breadcrumb, classical breadcrumb appearance of MTB. So the transmission is usually aerosol, respiratory route, and the droplet spread is the major killer here. So each cough of a TB patient will have, or it will have 3,000 infectious droplets, and each droplet will have around 10 power 5 bacilli of this MTB. So you can imagine the exposure of an emergency physician if he's not having a barrier for this. And even CDC says that to declare a person negative, we have to have at least 3 smears, sputum smears on different days as the criteria for removing the person from isolation. So there are 4 stages from which this pathogenesis occurs. The first stage begins when the alveolar macrophage phagocytes this inhaled bacillus. Now this macrophage, if the host is resistant to this, he's having good immunity, it will end here only. This will kill the bacillus and it will end. But in case the host is not having resistance, this will proceed, and this virulent bacillus can overcome the macrophage. It will sit inside the macrophage and it will start replicating. So this second stage occurs when this bacilli starts replicating, and this will cause lysis of the particular macrophage. This lysis will cause chemotaxis of all the surrounding circulating monocytes, the cellular debris, and all of these will form a foam cell macrophage. Now these monocytes differentiate into macrophages. They again ingest the free bacilli and keep circulating. So this forms a tubercle. This is the primary foci of infection for a PTB. The infected macrophage from here can be transported to lymphatics. Preferably they go to the lymphatics, and from there they will release the bloodstream. So during this spread, the pathogen tends to go and sit in the long bones, epiphyses, the kidney, the lymph nodes, the vertebral bodies, and the meningeal areas, preferably in the apical areas of the lung due to the higher aeration of that apical apex. So the stage 3, it begins after 2 to 3 weeks of initial infection and with development of the immune response. So once the patient develops a cell-mediated immunity, he will start fighting back. But this will occur with the CD4 T helper cells. And this sequence is seen in immunocomponent also. So the patient, if they are immunocomponent also, we can see this sequence. But usually the CD4 count will be less in compromised. So those patients are more susceptible. And this up till here, it is dormant and subclinical. So the final stage can occur anytime. It will be usually suppressed and it will come out anytime. And this is where we will see this clinical stage of the TB. So this dormant foci is responsible for almost all the major manifestations of post-primary TB. So this primary wall of tubercle, as we have discussed, may erode, and this will start oozing out slowly into the bronchial walls, into the pleura, and it will start causing symptoms. This is having a central caseous necrosis, and this entire necrotic area is teeming. It is, it's full of bacteria, and this might also go out of the lung, and it cause extrapulmonary TB. So this spilling of the liquefied material in the lung will cause extensive pneumonia, and might cause ARDS also. So these are the stages, as we have just discussed. The clinical features, I think every doctor knows about the clinical features, which are usually weight loss, anorexia, fatigue, and chills. Fever is the most common. So classical is the fever which develops in the afternoon and evening, and later causes defeverance during the later part, and it is the night sweats of the TB which are classical. The cough, the patient says we are having, first we had dry cough, then it became purulent productive cough. So this is the symptom, classical symptom. And hemoptysis, it might be due to sloughing off of this caseous necrotic part, and it erodes and causes a minor hemoptysis initially. But there might be major hemoptysis also, which we will discuss. SOB and dyspnea might not be very clinical, because unless until there is a large lung parenchyma damage, it might be prominent. So patients who are having advanced HIV infection will have both extrapulmonary and pulmonary TB presentations. So the emergencies in TB might be very less, but they are very significant. So pulmonary TB specifically, I'm not going to stray away from the topic, and I will finish it quickly. So let's talk about the first one, which is massive hemoptysis. So the destruction of the lung parenchyma by this particular tubercle, tuberculoma, granuloma, this will cause destruction of this parenchyma, and it will rupture the surrounding blood vessels. This erosion will cause, if it goes into the pulmonary artery. So basically pulmonary artery and bronchial artery. The pulmonary artery is a high volume, large volume, and a low pressure system. Bronchial artery is a low volume and a high pressure system. So if it is going into the pulmonary artery, it will form a pseudoaneurysm called as a Rasmussen's aneurysm. This will cause as fatal hemoptysis. But if it is further going into the bronchial artery, that is where it is causing life-threatening major hemorrhage. So massive hemoptysis defined as loss of at least 600 ml of blood in 24 hours. This is the definition. And this emergency resection of the lobar resection, or might require selective embolization. So this massive hemoptysis, ABCs of this would be, first we have to always support the airway, secure it if needed. We have to go ahead with large bore ET tubes more than 7.5, and we have to, next is ventilate adequately. Go for adequate pulmonary toilet with suction, and then we can go for drowning the lung. So this is a selective drowning. If the hemoptysis on the X-ray, we can see if it is from the right lung, we have to put the right lung right side down. So we have to make the patient lie on the right side. So this will cause drowning of the lung while ventilating the normal lung. So the normal lung can be ventilated selectively. And then we have to selective intubate the main stem bronchus. So right or left, we have to identify and then go and intubate that. We can push it to that main stem bronchus. Then we have to go for fluid resuscitation, or if required, blood. Right. So next is the pneumothorax. Pneumothorax may occur when the tuberculous cavity ruptures, and this will create a bronchopleural fistula, or this bleb might enter into the pleural space. This will create a pneumothorax. If the treatment of pneumothorax will be ICD placement, and we have to put it under underwater seal suction. And if this is not done, this will progress, and it will cause fibrotic pleura, and it will cause air trapping and further worsen the pleural space. I will discuss it now next. This is a image showing bilateral consolidation, and there is a thin pleural line. You can appreciate it. This is not. So there is a very thin, on the left side, there is a very thin pleural line we can see of the, indicating that this is a pneumothorax. So pleural effusion, the pleural TB occurs usually with primary PTB, and it comes with pleurisy, pleuritic chest pain, and effusion. The definitive diagnosis of a TB pleural effusion can be done with microscopic and chemical examination, and the pleural tissue biopsy can be sent. The WBC count is usually above 500 to 2,500 cells, and the fluid is exudative in nature. It has protein more than 50%, and glucose concentration may be normal or low, as seen in bacterial infections. So this is a whiteout lung on the right side with causing a tracheal deviation to the normal side. So this is a pleural effusion. There empyema. So once this progresses, it can cause empyema. So empyema is characterized by an extensive progressive parenchymal disease and cavitation. The rupture of this cavity into the pleural space is very dangerous and often occurs in a neglected patient. So this will cause a bronchopleural fistula, and if it is neglected at this stage also, it will go into a pleurocutaneous fistula. Pleurocutaneous fistula, where from the skin of the patient, there will be pus oozing out, and this will eat out everything, the chest wall, the ribs, the vertebrae, everything will be eaten up by the bacteria. So this is a X-ray image showing a large cavity which is drained to see a lot of pus-filled drainage, and that is the CT image. So next is a most often neglected form of airway TB. So this is usually occurring when the cavity is draining the highly infectious material into the bronchial tree. So we always see which is coming out, patient is coughing like me. So patient is coughing, and the spread while coughing, it will come out, the droplets will come out. So while coming out, the bacteria will also try to attack the bronchi, main trachea, bronchi. All of these are also prone for this disease. So this causes bronchiectasis, and this causes endobronchial TB. So the bronchial stenosis from extensive damage will directly cause this. So it would be lymphatic spread, hematogenous spread, or while the patient is coughing up. So this can all lead to endobronchial TB. So this is a first image. Here is a bronchoscopic image of bronchus. So we can see it is narrowed, it is stenotic. Next, we can see the sagittal section in the CT down here, C, where the trachea is stenosis. So we can see this is actually an emergency situation where we have to go for either tracheostomy. Sometimes tracheostomy might also be difficult because of the stenotic area. So laryngeal disease is the most infectious form because the primary foci of infection is right there in the posterior larynx. So it is usually due to the extension or pooling of the secretions in these patients who are neglected or who are bedridden, in whom we were unable to suction properly. These patients will develop laryngeal TB and cause. So TB pericarditis, which can progress to tamponade. This is most serious complication, emergency TB. So this occurs in immunosuppressed, like all of them, but the presentation will be not like a common pericarditis. It will not have an acute painful pericarditic picture. So this will have a constrictive type of effusive pericarditis. So here the patient will develop it over several days to weeks. The chest X-ray will show that patient has an active PTB. And also sometimes the patient has pleural effusion. So the echo image we have attached. So this will show fibrous strands in the pericardial effusion, and there will be echo densities we can see in the pericardial surface. So the treatment would be immediate pericardiocentesis if there is tamponade, and if the patient is having recurrence of this, they have to go with pericardectomy, and ATT full therapy should be started before and after the surgery. So this is an X-ray of this pericarditis, which is having a calcified pericardium, which can be appreciated in the X-ray. So The prevention of this in the emergency department would be early identification. Like we have to suspect every patient coming up with chronic cough more than weeks. We have to suspect that they are a carrier of this disease, and we have to isolate them. So we have to keep isolation, respiratory isolation rooms. I hope COVID has taught us something. So we have to have negative pressure preferably. So negative pressure isolation rooms must be there, and environmental control must be there in that. And patients, providers, healthcare providers must have personal respiratory protection with HEPA filters or at least N95. And patients must be also have kept surgical mask at least on them. And the preventive therapy after exposure for the healthcare professional must also be initiated. And PPD or tuberculin test can be done after 2 to 8 weeks of exposure, and then they can be started with full course of HRZD for 2 months and then HRE for 4 months. So all of these must be prioritized, and that's all. Thank you.
Thank you, Nayan. You have well articulated the concepts of the pulmonary tuberculosis and its varied presentation in the emergencies. Yeah, he has nicely described like how immunocompromised persons are more prone to, it is notorious in the presentation. So to describe as such, the spectrum of TB as such makes its diagnosis more difficult. The emergency department presentations of the tuberculosis are such a wide and vast that it is very difficult to diagnose. So our presentation was mainly pertaining to the emergencies in the pulmonary, only pertaining to the pulmonary tuberculosis. If we consider extrapulmonary tuberculosis also, and it is wide and vast. Here it was very well described by Nayan, and very notable is the immune reconstitution inflammatory syndrome presenting in the HIV/AIDS patient, and also the emergencies which he described in the normal patients. Sometimes it may land in ARDS, DIC, and finally leading to death. Thank you, Nayan.
Thank you.
Any questions? Maybe we'll take at after the end of the session.
Okay, thank you, ma'am.
Thank you so much, sir, for such a great talk. And we are going to next topic, management of ventilator-associated pneumonia. And I'm very glad and honored to invite Professor V. Chandrasekhar, sir, who is a professor and head of the Department of General Medicine in Government Medical College, Mulugu. And I request Dr. Pradhan, sir, a chairperson, who is one of the main pillar in the Department of Emergency Medicine, and he is the assistant professor in the Department of Emergency Medicine, MGM. And I now kindly request Dr. Pradhan, sir, to introduce Dr. V. Chandrasekhar, sir.
Good afternoon, everyone. I welcome Dr. Chandrasekhar, sir. He is a professor of medicine, Kakatiya Medical College, ex-professor, and he is a ex-medical superintendent of MGM Hospital, and he is a former principal of Kakatiya Medical College, and he is an EC member and RSS DI Telangana State Chapter, and he is a postgraduate teacher in medicine for 25 years. He addressed many national and international conferences, and he is a regular faculty in APCON, RSSDI, and ACPCON, IMA, and he published many articles, papers in national and international journals, and he contributed chapters for Medicine Update and monograms. And I welcome Dr. Chandrasekhar, sir, to continue his session.
Yes. So good evening. So post-lunch session, maybe 40 minutes are over. Now I think you are very alert after a few naps of sleep. So actually for this conference, Ashima madam is a scientific chairman. I am organizing chairman. So all topics have been selected by madam itself. So why I am telling all these things? Because so when first we have charted out the talks, and then I have a doubt, what are emergencies in the tuberculosis? Then who will take that? So ultimately, we thought of someone, but Nayan has did a wonderful job. And the coming topic also, ventilator associated pneumonia. So I think no takers were there from emergency medicine. Who will? So I will take, madam. So that is how it has come to me. So I'll throw light on some important aspects. It's like an overview of ventilator associated pneumonia. And I thank Dr. Ramkumar Reddy. He is Principal Kakatiya Medical College. And he is the founder HOD of Emergency Medicine, Kakatiya Medical College. So actually he came to chair a session, surgical this thing, but unfortunately the topic has been cancelled. He himself is an orthopedic surgeon, very good surgeon. Moreover, he is a very energetic person, sports person, and is very good friend of me. After this session, I'll call you for the on stage. So this is, yeah, I'm sorry. So this is ventilator associated pneumonia. So coming to the definition, we know it is an infection in the pulmonary parenchyma in patient exposed to invasive mechanical ventilation for at least 48 hours. So if anything comes before 48 hours, it may not be ventilator associated. And it is a part of nosocomial infection, particularly ICU acquired pneumonia. And it has a significant impact associated with the mechanical ventilation, and it causes the increase in the ICU stay, so that the economical burden also. So coming to the epidemiology, so this pneumonia affects 5 to 40% of patients who are receiving invasive mechanical ventilation for more than 2 days. Incidents vary with where from the data is coming from, but usually depends upon what is the ICU type. So whether ICU is following all the very advanced ICU, following all the infection control measures and all. So whereas in North America, 1 to 2.5 cases per 1,000 ventilator days. But in European Union, one study says that 18.3 episodes for 1,000 ventilator days. So it is varying, but what I mean to say is it's a very significant high incidence is there. So coming to this incidence, it all depends upon which patients you have mechanically ventilated. So probably the cancer patients who are ventilated will have 24.5%, whereas polytrauma patients who are ventilated, 17.8%. And as usually the chronic obstructive pulmonary disease patients. Underlying conditions, if the ARDS patients show high VAP rates, 29%, and persons who are kept on ECMO has further high 35%. And age doesn't have any significant effect, but male gender is a little more prone for this ventilator-associated pneumonia. So the outcomes of the mortality, I already told you, mortality is as high as 50%. So for what purpose we have ventilated, so that we may succeed. But later on, because of this complication, patient might die. So, and that is all-cause mortality. Attributable directly to this ventilation is 9 to 13%. And it subsequently increases the hospital length. So that is also one of the parameter. So coming to the microorganisms most commonly responsible for this pneumonia is a gram-negative bacteria, particularly Pseudomonas aeruginosa, Escherichia coli, and Klebsiella pneumonia, and Acinetobacter species. So gram-positive also will cause, most of the times it is Staph aureus. And fungi viruses also, like Candida species and Aspergillus species also can be responsible for this pneumonia. So there are two subsets of ventilator-associated pneumonia, early onset and the late onset. The early onset is said to be, so if the infection happens within the first 4 days of hospitalization, so usually it is in this patient, the oropharyngeal flora is very normal and they seems to be healthy patients not receiving any antibiotics prior to this episode. So 90 days prior to this episode. And second variety is the late onset pneumonia that happens after the 5 days of hospitalization. And this is especially important because this late onset is associated with most of the multi-drug resistant pathogens. And what are the risk factors for these multi-drug resistance pathogens? So persons who are taking antibiotics prior to the 90 days of this episode. So who have the prolonged hospital stay, because anyhow it is coming after the 5 days. So any prior colonization with MDR pathogens is also one of the risk factor. And so what are the various types of multi-drug resistance pathogens? One, ESBL producing Enterobacteria. So they are resistant to third and even fourth generation cephalosporins. MDR pseudomonas. It is a very difficult. It is increasing in the prevalence and challenging to treat. And carbopinamase producing statins, a growing concern because of again their resistance to carbapinum and latest antibiotics also. So carbapinamase resistance Acinetobacter baumannii is 1/2 to 2/3 of strains causing ventilator-associated pneumonia or carbapinum resistance. So this is the spectrum of MDR in VAP. So how to diagnose this condition? First is the high index of clinical suspicion, and second is the radiological criteria, particularly new and progressive and persistent infiltrates. And third is the microbial cultures, positive cultures from any lower respiratory tract specimen. Clinical signs include fever, any purulent endotracheal secretions, leukocytosis or leukopenia, increased minute ventilation and decline in oxygenation saturation, and increasing the need for vasopressors. So these signs are not very specific to the VAP. So sometimes we cannot depend, but it is how to investigate, go for the investigate. So coming to these limitations of the clinical diagnosis. Clinical diagnosis, what I said, all the factors is by clinical pulmonary infection score, CP score. So it will be 6 variants. So if anything more than 6 is high likely to be a ventricular associated pneumonia, but this scoring has a very low specificity. And coming to the X-ray, chest X-ray is neither sensitive nor specific, but CT scans may be more sensitive, but some drawbacks because all the settings may not have that feasibility, and particularly there may not be safe in transporting. But ultrasound, lung ultrasound is a one promising. In the morning sessions we have heard about this. So probably in future days this may be one of the important investigation for the diagnosing VAP. So biomarkers said a lot of things, but there is no much thing to be. CRP lacks accuracy, and procalcitonin is not recommended for VAP. This S-term 1 lacks accuracy for VAP diagnosis. In future, may some of the biomarkers will come for the early diagnosis, but as of now, there is no very specific on which we can depend on the diagnosis. So the compulsory most diagnostic with specific diagnosis is microbiological diagnosis. So it involves the sampling techniques, invasive, non-invasive. Invasive like bronchoscopic guided methods like bronchoalveolar lavage and what is called potential specimen brushings of the tracheal this thing. And non-invasive also blind mini ball and endotracheal aspirates also you can take it. So it has both quantitative and qualitative cultures. So whether present or not, if what is the colony count, both we can have. So there are advantages and disadvantages in the sampling techniques because invasive techniques is having higher specificity for its advantage, but it requires a qualified person. Sometimes it is not possible. There are potential risks for the patients also while doing the procedures. And obviously higher cost is, these are the three disadvantages. Coming to the non-invasive, it is simpler, quicker, but the fewer complications, but overestimate the bacterial presence and potential to cause unnecessary antibiotic. If the overestimate, unnecessary antibiotic we may be putting. So both advantages, disadvantages are there. And emerging microbiological tool for the diagnosis, conventional methods, but usually it will take 24 to 48 hours for the culture report to come. In this scenario, the second thing is PCR-based methods, faster identification will be there, and multiplex PCR, wherein it can allow the multiple pathogens, particularly with resistance. So as in the case of TB, we will do the TB NAT test where the rifampicin is resistance or not. So something like that for all these things are there, multiplex PCR, and future diagnostics may improve in this regard. So which help in the antibiotic stewardship, so which is needed in the management of VAP. So coming to the surveillance part, because lack of consensus and need for the objective criteria and ventilator associated events, so all these things are not very specified, but though, so for all the epidemiological purposes, if we have a collaborative VAP surveillance from all the centers, so which will throw a much light so that we can go further to prevent this VAP and as well as effectively manage the VAP. So preventive VAP, so the oral care with chlorhexidine is one, they say, because it is the oral colonization which may travel down. So, but some says that it is maybe harmful because increased mortality is seen in some of the studies. And selective decontamination may not be effective in ICUs, but in other wards may be useful with a high baseline rates of the antibiotic resistance. So stress ulcer prophylaxis also potentially associated with higher VAP rates. So GRD is a one which is increases the chances of VAP, but whereas the ulcer suppression also will promotes the bacterial growth. So there is a mixed reports about this stress ulcer prophylaxis. Subglottic secretion drainage is also one of the VAP bundle. So may not shorten the duration of the mechanical ventilation. ICU length of the stay is previously as it was thought, it was not so promising. So coming to the preventive strategies, avoid the intubation itself first. So we were discussing about so many in the ABG analysis also, whether it is indicated or not. So even if it is indicated, go for the minimizing the sedation because the natural drive has to become. So minimize the sedation and early extubation where it is possible and early mobilization because these, if you are not going for the early mobilization, it will increase the risk for the development of VAP. So VAP prevention is the better. So coming to the bundles, there are VAP prevention bundles are there, head of the bed elevation and oral care and subglottic secretion. But all these studies suggest the bundling practices focused mainly on the minimizing sedation and encouraging the early extubation. Effectiveness of these bundles, particularly for the early extubation and the lower mortality rates, have been proved, but still some more randomized trials to confirm how far effective these VAP in these bundles. So coming to the treatment, there are two-step approaches. Step one, empiric treatment, we are giving all. But choice and immediately we have to start the antibiotics depends upon the disease severity and risk factors for any multi-drug resistance pathogens are there. Step two is the definitive treatment that we start after the culture reports have come, aimed at the avoidance of the overuse. Step two is de-escalation. So it is mainly to avoid the overuse of antibiotics. So goal is between these two where you are. So balance you have to achieve between avoiding ineffective treatment as in the case of step one and reducing the broad spectrum antibiotic consumption and de-escalate. So this balance has to be arrived. So empirical treatment consideration, the severity of the current illness and any risk factors for the MDR pathogens are there. So particularly any recent antibiotic use and any prolonged hospitalization and local resistance pattern. So each hospital should have their own antimicrobiogram so that they can, because it is basically hospital-based infection. So the institution ICU should have its own antibiogram so that we can choose in the empirical treatment for a quick success. So underlying diseases also, because I said risk factors like cancer, COPD and all, so that comorbidities, number of the comorbidities add to the problem, so that also be taken care. And local antimicrobial susceptibility pattern also you should know. So based on which we can start. So what are the range of the empirical antibiotics can be considered? So for example, if the early VAP, there is no MDR risk, you can directly go non-pseudomonal third generation cephalosporins, or you can go up to fourth generation cephalosporins. But in the case of late VAP, but MDR risk is there, anti-pseudomonal beta-lactam plus aminoglycoside or fluoroquinolone. So this is the starting therapy for the late VAP. So if the MRSA risk is there, add vancomycin or linezolid. So carbophenamide resistant bacteria, consider the new beta-lactamases like ceftazidime, avibactam, something like that. So for the pathogen specific, after the culture has come, we know what is the culprit microorganism. So try to de-escalate, narrow the antibiotic once the culture reports comes, and targeted, use the narrow spectrum agents rather than the broad spectrum agents. And discontinuation, if possible, if there is no organism at all, you stop the antibiotics, and mainly this focuses on monotherapy. So switch to the single agent treatment once the pathogens are identified. So duration of the antibiotic therapy, mostly it is 7 days treatment, so which is recommended for in the most patients, particularly with the gram-negative bacilli infections. But there are situations where more than 7 days extended treatment is required, particularly in immunocompromised patients and other suffering with other complications like emphysema and lung abscess. But less than 7 days shortened course is not currently recommended. So, but procalcitonin guided therapy may allow in few subsets of the patients. And coming to the nebulization antibiotics and VAP treatment. So currently, this nebulized antibiotics is not recommended, but it can be restricted to the patient's VAP due to extensively drug resistance, gram-negative pathogen susceptible patients only. So susceptible who are only for the colistin and aminoglycosides. So in that cases, there is a decreased bacterial resistance also. So for that benefit, it is indicated, but not full-fledged evidence is there with properly planned randomized control trials. So the future treatments, pathogen-specific antibiotics may come under investigations, antivirulence agents also, because the mycobacteria, microorganisms will cause infection when only they are more virulent and or the host is weak. So antivirulence agents and ongoing research is going on this. Coming to the management of viral reactivations in VAP. So herpes simplex may be silently may be there, but acyclovir treatment showed change in the ventilator-free days, but not overall mortality. Like that in cytomegalovirus also, antiviral prophylaxis studies showed mixed results. So in this area also is one blank area where further research is needed to treat this one. So coming to the management challenges, one is diagnosis because lack of the gold standard diagnostic test. Treatment is balanced between the broad coverage with particularly antibiotics stewardship should be there. Prevention is the better, the implementing the effective strategies without harm, and surveillance is the need of our. Without surveillance, we cannot overcome any challenges which I was telling you before in the diagnosis and in the management. So it is a very important problem. Economic impact in the US is somewhere around $40,000 for one VAP case. So in India, you can convert into this one. And I already told you that for 5 to 40% of the incidence is there. So every ventilation every second ventilation is associated with this one, and that much costs are added. And 7 to 9 extra ICU days once this VAP is diagnosed, so that much cost is also going to be added. So that is why it is very important. And coming to the future directions, diagnostic biomarkers may improve. Rapid pathogen identification is the one, like that multiplex PCR and all. Personalized treatment, tailor-made antibiotic regimens based on the patient characteristics and pathogen characteristics, and novel preventive measures. These may be the future in the VAP research. And coming to the conclusions, diagnosis, I told you microbial confirmation is strongly recommended, and treatment is initial broad spectrum followed by de-escalation to one therapy. 7 days is sufficient. Prevention, please focus on that. Thank you very much for your patience here.
Thank you, sir. An excellent presentation by Dr. V. Chandrasekhar, sir. And regarding the VAP, I request postgraduates to use proper hand washing technique before administering or before doing intubation, because most of the intubation techniques, the staff or the brothers, they will give intubation tube to the postgraduates. They will handle with the bare hands. This is the most possible chance of getting ventilator associated pneumonia. So we need to prevent the VAP by proper hand washing technique. And I use this stage to thank two pillars of emergency medicine department, as said Dr. K. Ramkumar Reddy sir and Dr. V. Chandrasekhar sir, for establishment of emergency medicine department in MGM hospital. As it was not established in Mandi and Usmania, it was established, and we got already 5 PGs and we are expecting 5 more PGs. And because of their constant effort, now we are up to this stage. And I also thanks to Dr. Ashima Madam for her constant support and making this conference a success. Thank you.
Forgotten that hand washing technique, the first step in prevention of any infection, including this one also. So I request Dr. Ramkumar to come up onto the stage, and Dr. Ashima Madam also come up onto the stage, and that memento presentations she will announce. Next to Vishwa, speaker, me, Pradhan.
Now I kindly request Dr. Ashima ma'am and Dr. Chandrasekhar sir and Ramkumar Reddy sir to present a memento to Dr. K. Vignan sir. And I request Dr. Joshua sir to present a memento to Dr. K. Vignan sir. And I would kindly request Dr. Vishwa ma'am to present a memento to Dr. Nayan sir. And I request Chandrasekhar sir, Ashima ma'am and Ramkumar Reddy sir to present a memento to Joshua sir. And I would request Dr. Chandrasekhar sir, Ashima ma'am and Ramkumar Reddy sir to present a memento to Dr. Pradhan sir. And I request sir and ma'am to present a memento to Dr. Vishwa ma'am. I request Dr. Ashima ma'am and Ram Kumar Reddy sir to present a memento to Dr. V. Chandrasekhar sir. And I request Dr. V. Chandrasekhar sir, Ram Kumar Reddy sir, and EMD department from MGM to present a memento to Dr. Ashima Sharma ma'am. And I request Chandrasekhar sir and Ashima ma'am to present a memento to Dr. Ram Kumar Reddy sir.
Additional DME and Principal Kakatiya Medical College to address this gathering.
Good evening, all the delegates and faculty, chairpersons presented here. I'm very happy to be present here as a guest or maybe, okay. So, on this stage, many budding emergency physicians are there. I speak out few of my heartfelt things to you on this, from this stage. You are the first emergency physicians. So you need to make few sacrifices to develop this subject in India. Why? Because as administrator, I am seeing very much difficult to get the faculty to continue the department. You might be knowing emergency medicine is a subject which is made compulsory for the UG recognition. But recently, from last year, it has been removed as a compulsory subject for the undergraduates. Why, you know? Previously, it was a compulsory subject in the college that should be there for the UG, NMC, in a department in medical colleges. If you made the rule that emergency medicine is a must for a UG curriculum, so there are many colleges are not getting recognition. That's why even if MEM hospital or Kakatiya Medical College, where it is a almost 60 years old college, very renowned institution, we are not getting faculty. So this Pradhan is one of the main pillar for getting our PG seats. We are getting 5 PG seats from the medical college. I am, by holding his collar, I am keeping him in the medical college. Because you people have been very demanded person in the society. You are being many opportunities in the society and you have good practice outside. That's why you people are settling in other way. But what happens to the teaching? What happens to the department? So this is a big question. You have to think yourself. Please make few sacrifices from your side so that this department will grow like anything. In this context, I remember my teacher, Vagreshwarudu. You know, I think many of you might not be knowing, orthopedics. Vagreshwarudu was my guru at that stage when I am UG. I written a book also. There's a small book, there's a pioneer book, first book in the India, actually. So at that time, there are no orthopedic subject previously. Actually, it is a part of the general surgery. There was no subject in orthopedics. So when he is doing a PG, he doesn't have any teacher to give a guide, give a thesis work. So what he has done now, he has written a thesis on his own. He himself signed the thesis as a guide. For recognition, he sent that book to the UK. So Liverpool. There they read the total content and they approved it and they given, so okay, this thesis can be accepted like that, they given and they sent back that book to the India. Then that is accepted as our thesis for the UG presentation or the PG degree presentation. So that contest is just remembering because you people also have to do such work from your each departments. Each one of you please join in the departments and improve your departments. Ashima madam is there. We are regularly contacting her, madam, whenever we have some doubts. Because I am an orthopedic surgeon, so orthopedic surgeons, physicians, and the anesthetists, they are allowed to chair the department because the very emergency physicians are not available. That's why we have given option. If emergency medicine physicians are available, they will become HODs. I have been there as a HOD for 5 years, and with the help of our Chandrasekhar sir and Pradhan, we maintained the records and we done everything. And at the last, we got 5 seats of PG, postgraduates. But presently, we do not have the faculty. If again the emergency comes, we don't have the enough faculty to continue that PGs. So now I am sending that PGs to the various departments in the state. As a principal, I am sending them for learning and training because there are no qualified emergency medicine physician in the college. So that I am requesting Ashima madam to take some 1 or 2 months training, some Kamini, some 2-3 months like training. Like that, I am sending them as a deputation there. Why? Because we have department here, but nobody is joining. So you may have your personal developments, but I plead every one of you, make few sacrifices and improve your departments because you are the pioneers of this department. So you should please be some responsible to improve your departments. So thank you very much. So maybe this is a big request from me, but you just think in a bigger view, bigger picture in the future. So after 5 years, this request nobody will make you. But if you head a department now and if you are working that, you will get a good name and fame in the future life. Thank you very much. Thanks for giving the opportunity for this. Thank you very much.
Fine, sir.
Coming.
So sorry for keeping whoever is still remaining, but although this might not be the most awaited session, hopefully it will be a little rewarding if you hard enough. So please get your phones out. Just to say that only PGs are going to participate. This is not open to faculty. Yeah, I should have re-announced it. Your gifts, ma'am. Sir, okay.
Hello, hello.
So please scan the QR code to join. And just to be clear, this is the fastest finger first type thing. Apart from the correctness of your response, the quickness will also matter. Okay. Yeah. Just request you to enter your real name, please. Rejoin with your real name, please. Okay, I think we are okay. 18, 19. All right. Okay, I think we'll start, and you'll be able to see how much time is remaining to the right side. So let's go. So the questions are going to be visible on your phone. You don't have to keep looking here. On your phone screen only, it's going to be better. Unfortunately, the GIF isn't working, but there's enough on there for you to answer. If everyone submits their responses, it will move on. Right. Nice. Okay. Too early to say anything. So there are 3 prizes. Don't give up easily. It's not just one. Okay. Okay, moving on. Nice. Okay, he tends his position. Next one. Is the visual visible reasonably well on the phone? On the phone. No, it's visible fine. See, sir, see. Array. Okay. Good. Going to 7. We can. We are getting updates after each question. The leaderboard is getting updated after each question. – 15. And we'll stop at 15. Okay. Okay, moving on. Tenses position. I think 30. I think I can skip this at 30 seconds. Sorry, not skip. Okay. So, I request Dr. Chandrasekhar sir and Ashima ma'am to do the honors of giving away the prizes to the top 3. Yes. Dr. Vaishnavi and Dr. Pranati, please come over. Dr. Vaishnavi. Ma'am, you can also join. Ma'am, both of you give together, please. Dr. Pranati.
So I request Principal Sir to give a memento to Najibuddin. He is also organizing secretary, along with Pradhan. So, madam, you stay back. So, anyhow, we come to the end of the program. But at this juncture, I want to thank Sun people because who are the sponsors of this program. So, though our organizing secretaries, both Najibuddin and Pradhan, and along with madam and myself, added some inputs, but to materialize this, Sun people were working like anything for all these 15 days. So I immensely thank Mr. Pradeep. Please come on to the dais. And Ashok and other two guys are also there from Warangal, Satish and Dharmaraju. Please come on to the stage. Have a group photo. So otherwise, if I don't thank Sun people, it will be my mistake. So that is the thing. Now I request Pradeep to address this thing and also vote of thanks by you to end this program.
So good evening, everyone. Sir, first of all, thank you very much for giving this opportunity. This program will come, but without sir and madam, we could not able to any program, it would not be this much big success. So once again, thank you very much for all eminent speakers and chairpersons and all the delegates who are come for this program and making this big success. Always Sun Pharma will be in forefront for doing such programs. And I wish you all the best for all the PGs. And thank you very much for all the eminent speakers and chairperson, especially Chandrasekhar sir and Ashma madam. And Sun Pharma, we request for